and then I can change the setting. And then you can also make me the host.
Recording in progress.
You make me host? Yep.
Yep.
Okay, so I can change the setting.
Now, do we have to do it to all of them?
What do you mean?
Should I delete the rest of them and then go back? Because it must have been a settings I didn't click when you initially set up all the meetings.
No,
No.
I just gotta remember how I did it last time.
Because on my EMT one, it doesn't, like, I don't have to let people in. It just, they automatically can join.
Disable the waiting room. Did this before and it was not that hard. I'll do it. I had to wait until someone was in the waiting room and then I could do it.
Hey, Kevin, how you doing?
Hey, good morning, guys. I'm doing good.
There we go. It should be disabled. Capnography step up. And then I found a handout that when we take our break, we can copy that has capnography stuff on it. You can teach me how to copy.
Yeah. Yeah.
Yeah, we'll wait for a few minutes to let people join. I guess I'm doing this without caffeine. It's fine. I'll be okay.
What do you like? I'll run over there and grab it.
I don't even have my wallet. I'll
That's
okay.
all right. It's not too bad.
An Americano with 4 shots and a little bit of heavy cream.
Americana, 4 shots, heavy.
Yeah, thanks. Okay. Submitted our Viper contract this morning. All 15 of them.
Is it too late to send my stuff over to you?
Yeah.
I realized I forgot to do that.
Yeah, it's okay. I mean, we can fudge the roster a little bit when the season starts, like, not the end of the world, so.
The what?
I deploy people on fire,
Oh, got it. Okay.
and the Viper contracts are due today well, they're technically due at 6, but there's like 15 of them due nationally, so like, if you wait until anywhere after noon, the system just crashes. Like last year, they had to leave it open for a whole nother day, because there were just too many people on there. So, because like all the heavy equipment and like shower trailers and all that stuff is up right now. So,
I need to see a federal system working like that.
oh yeah, yeah. And then they got rid of, I don't know if you heard this, they got rid of the Boise Dispatch Center. So now Missoula's like the dispatch, it's like Missoula and then New Mexico.
I didn't hear they got rid of Boise.
Yeah,
What was,
I
I
like
feel
went
like getting
on,
rid of Boise is kind of like, wasn't Boise?
It was the big one.
Main,
that was the main dispatch center, yeah. They like shut it down and I
that was
like,
AWCG headquarters.
yes.
Yes.
And I like, cause I went
That
to,
makes sense.
we have some people in Mountain Home and I was like, oh, that's great. They'll just dispatch out of Boise, cause I'm like 45 minutes from Boise. And it wasn't an option. And I like called the contracting officer. I was like, where's Boise? And they're like, yeah, great question. Like, so what about Oregon and Washington? They're like, yeah, Missoula. It's all Missoula now. So they got rid of, they combined, the Missoula whatever it was called, the Missoula Interagency Dispatch and Coordinating Center, what, MDCC. Yeah, I looked at it like 10 times today. I can't remember the name. Anyway, so I got rid of that.
The NICC.
Yeah, something like that.
Or no, this is the regional.
It was the regional one, yeah, they combined it, I guess,
Yeah.
so.
I mean, I guess it's in general a net positive for you.
Yeah, well,
Because
they
you're gonna
kind
get dispatched at the same time as all of the Oregon and Washington
yeah,
contractors.
it kind of-
More people.
the weird thing is, you had to be like, depending on the resource, you had to be at X amount of miles away from your dispatch center.
Hmm.
And now I'm like, does that not matter anymore? Cause there's like one dispatch center in the Pacific Northwest.
And that, I mean, that can't be for everything, because I know,
It depends on the
because like,
resource.
I know fire resources, you can still, like, they can be out of,
No, technically, single resources have to be in the Viper as we.
well, but I guess like engines are still,
Yeah, I said it depends on the resource.
yeah, are still, there's dispatch centers all over the place for those.
Yeah,
I'm curious
yeah.
what all resources they.
But there's some interesting legislation that went down with that stuff, so. Okay, so we're gonna get started. I think I have a couple people online. I think I got rid of the waiting room. If I did not, and you guys cannot get in, just holler at me, or you see people in the waiting room that shouldn't be there. I think I disabled it. So the first thing we're gonna talk about is capnography. I am not standing up. My surgery is scheduled for next Monday, so this is the last time you'll have me in person for this class. I might be able to make it in May a little bit, but I will be non-weight bearing for 6 months or 6 weeks, and then, yeah, so I'm pretty much not leaving my house. But you'll see me on Zoom. I will be there every class on my couch with my daughters. Okay, so how many of you guys are using capnography regularly? Yeah. Okay, so you have a little bit of a background with it. When I started, capnography was not a thing in the field yet. It did not hit the field until probably early, like around 2010. It measures your exhaled CO2. It is very useful to direct your treatment as an AEMT and then also help your medic. And it can diagnose a lot of things, and it also predicts outcomes in things like sepsis and what else?
ROSC. And it also helped predict ROSC.
Yes, ROSC, yeah. I heard cross. I was like, what's that? Oh, yes, ROSC. That last code that I ran, it was a strange one because he had a CO2 of like 30 the entire time. And I was like, that can't be right. Like, you've been in VFib for 50 minutes. Like, we never figured out what was wrong with that. So there are a lot of different devices out there. Most agencies that I am familiar with use one that you just plug into the monitor. A lot of Lakeside might have had I think for a while we had like a portable one. Do you guys still have it?
No, we use the
No.
monitor.
The monitor now, yeah. The portable ones are really finicky. And the other thing is, I don't know if you guys know this, you cannot get water in that port or any sort of condensation or it'll ruin it. I did not know this. I work on a mountain, on a ski resort, and couldn't figure out why our CO2 wasn't working. And the Zoll rep came up and did our like annual maintenance, and he's like, oh yeah, you got water in there, it'll ruin that. So you have to really, really protect that. And we always complain that it's like, at least on the Zoll, that port is like really deep in there and hard to get to. That's why they want it to be protected. So you can do a lot of damage to your monitor, apparently. Didn't know that until we did it. So you have to be really careful, that you don't get any water or condensation or bodily fluids in there. So this presentation actually came from Bob Page. I don't know if you guys got to see him when he was here. He's like the cardiology guru. He's a great guy. He's also affiliated with the Boston program. So the #1 rule of life is air must go in and out. So the function of ventilation. So ventilation is the mechanical movement of air in and out. So there is a difference between ventilation and respiration. And a lot of people kind of use those words interchangeably. And ventilation, just remember when you're ventilating someone, it is the mechanical moving air in and out, right? Respiration is how that air gets pushed into the body, into the cells, and then ultimately does its thing. It's designed inherently in our bodies to eliminate CO2 and get that O2 in. There are a lot of chemical processes, that go along with this that we don't necessarily care about. There are a few things that you want to know. So the chemoreceptors in the medulla is actually what triggers ventilation. It triggers you to breathe.
Sharing the screen.
What?
Just sent.
Let's try again.
That was 4 minutes ago. Sharon? Check it out.
No. Oh, you have to, so now you have to give host back to me. Oh, reclaim host. Okay, I can do this. Share. And then it's this one, right?
All right, for those of you that are online and you see the screen now, what is it? You see what we're sharing?
Yeah,
Yeah,
you got it.
I can
It's
see
good.
it now, so we're good.
What does it look like? Turn it around so I can see it. Yeah, see, we want it to be the,
So then, yeah, you can.
I do this?
Yep, and that. There you go.
No. Oh, there it goes. It was just delayed. Okay. So I'll go back real quick and just show these slides. I'm not gonna talk about them. We'll just do this so you can see them. Those are all the devices. There's lots of them. Don't get them wet. Don't get any water in those ports. It ruins the monitors. I learned that the hard way at Big Mountain. Okay, so chemoreceptors are the big thing that triggers ventilation that are in your brainstem. The diaphragm then contracts and ventilation occurs. And then another thing that happens is the differences in temperature, the differences in pressure. There are a lot of laws. There's Boyle's law and Fick's law. And Kyle, do you remember any of the laws that govern any of these things? Because I sure don't. I don't really care. I took a lot of calc-based physics in college and then I probably forgot all of it. So until you get to like your critical care medic and you're using this stuff every day, it's not a big deal. The only one that maybe we want to know is like I think it's Fick's principle, which is gas moves from an area of higher concentration to lower concentration, which is what drives ventilation. Don't quote me on that though. So your hypoxic drive is another way that your body breathes. So it senses low O2 levels. It's the secondary drive to those CO2 chemoreceptors in the medulla. A lot of COPDers theoretically use this to breathe. Okay, so how many of you have been told a bunch of times, like, be really careful giving oxygen to COPDers, right? Why is that? And is it really all that true?
I think it's more of a long-term thing, isn't it? Like a hospital setting.
A hospital setting, home oxygen, we are not going to overload them with oxygen enough when we have them for this to be an issue. So there was a huge study that was done. I don't know if you guys have taken it's the art of resuscitation study class that Dr. What's his name?
Davis.
Davis. I can never remember his name. Dr. Davis does, and he was part of this big study, and basically it showed like, yeah, you're not going to do enough in the field in the moments that you have these patients. But still be wary, and also remember that these patients typically run a little bit lower, right? You're not going to get a COPD above 94 if they're in the later stages of COPD. It's going to be real difficult to do.
And it's not necessary.
It's not necessary, right?
That's
Yeah,
the key. Don't
They're-
make that a high goal.
yeah. They're absolutely used to being at that, 89 to 92%. So here are just some definitions. Tidal volume is the air moved in and out in one breath, okay? You guys have seen those spirometer things at the hospital that they make you do before you go home from surgery. They actually don't do that as commonly anymore unless you have respiratory issues. The anatomical dead space is kind of important. It's the air that is left in your lungs to keep those little alveolar sacs open. Usually about 150 cc's of air. And COPDers, chronic bronchitis, emphysema, all of those are very much affected by this. Or those pathologies affect this. The other one is cystic fibrosis. Those patients have an overproduction of mucus, especially in their lungs, which gets into that dead space, and they can't keep it open. So basically they end up drowning. And then that alveolar volume is the actual space that is available for gas exchange. It is not that much. It's actually pretty small. So it's like 350 to 400 cc's, and that is actually where the respiration, not the ventilation, this is where the respiration occurs, where that air is getting pushed into the capillaries, it's getting off, the oxygen is getting offloaded onto those red blood cells, so that's the actual respiration. There are a lot of different factors that affect this. We talked a little bit about all of the pathologies that acid-base disturbances, and this is very much tied to all of that. So hyperventilation, when someone's breathing too fast, can affect tidal volume. They're not going to get as much air in, and then hypoventilation, kind of the opposite problem. It's also going to decrease tidal volume. So hyperventilation is going to increase tidal volume. Hypoventilation is going to increase that tidal volume, decrease the tidal volume. So this is another one of Dr. Page's little pearls. An increase or decrease in tidal volume is at the expense or benefit of the alveolar air. So remember, there's only about 350 to 400 cc's of space where you're actually getting gas exchange occurring. So any sort of deviation from normal breathing is going to really affect that, right? So what is the definition of ventilation? We just talked about it. Someone tell me.
The mechanical.
It is the mechanical movement of air in and out. You are ventilating a patient, okay? This is one thing I harp on a lot because people, for some reason, really tend to mix these two words up and use them interchangeably. It is Fick's law. Look at that. I got one right. So this is the pressure differential between two spaces, right? So the air that we're breathing, the environment that we're living in, and our lungs, okay? So it basically says that the partial pressure between two containers, so the environment being one container, our lungs being the other container, gas is going to move from an area of greater concentration to an area of lower concentration. So that helps drive our respiratory rate. It is also essential for adequate cellular perfusion. You have to have a lot of different things for ventilation and respiration to occur without pathology, okay? So adequate number of red blood cells. Your hemoglobin, those red blood cells actually have to be able to carry the oxygen molecules, and then they actually have to be able to let go of them and deliver them. You have to have an adequate concentration of O2. Does anyone remember what the concentration of oxygen in regular air is?
21%.
21%. And then you have to have an adequate blood pressure to circulate all these things. Because can you see how pathology can happen extremely fast in a lot of conditions? Okay. So you have to have that physiological balance. This is kind of like a summary slide of all we've talked about so far up to this point. So you have to have, if you have normal ventilation but poor perfusion, you can think about things like pulmonary embolisms or cardiac arrest. You get that VQ mismatch. If you have abnormal ventilation, so they're not breathing effectively, but perfusion's okay, they probably have some sort of obstruction or they're hypoventilating. They're not getting enough air in, okay? And those little equations just say that in math equations. So if your brain works that way, that's what those are there for. So there is a lot of really good technology that has changed over the years and gotten much, much better. So we used to just have, does anyone even remember using these, the little colorometers? Where you like put it on and then you breathe into it and it turns the color. Gold is good, yellow's good, gold's good, purple's bad. We've kind of largely gotten away from these. We don't really use them all that much anymore. Like, so are you guys still stocking them?
Polson does, but they're only good for like 1 or 2 respirations.
They're only, yeah, you do it, once and then that's it. So kind of gotten away from those. This other picture on the screen is one of those that is, that I was talking about, that was like a standalone module that doesn't need the monitor. They're also really finicky. Not many places use them anymore. There are 3 forms of capnography that we're going to talk about. There's the qualitative, which is that color change. We're not really using those anymore. Then there's the quantitative. So this is the one that gives you just the value, the number. What is the normal CO2? 35 to 45. So if you have a patient who has a CO2 of 60, what's going on?
You're not breathing fast enough.
They're hypoventilating. It took me a long time to figure this out because it's backwards, right? It feels backwards to me. So if you have a CO2 of 20, what's happening? They're hyperventilating. Yeah. And I find that this number is most useful when you are ventilating for patients. And on my last code, I even found myself overventilating the crap out of this patient. And we all do, right? Like it's one of the hardest skills that we do. And then that third one is the waveform capnography. This is a quantitative value. This gives you a lot of information. We're going to go through what all of the different waveforms mean. And then I have a great handout that I'm going to photocopy and give to you by the end of class today. I'll also throw it on actually, you know what? I'll just put it on I'll just put it on Canvas so you guys can get it electronically. Unless you want a copy, those that are in the room, I can get it for you today. If you're paper people like I am. Okay, so some more street wisdom from Bob Page. So end tidal CO2 without a waveform is like a heart rate without an ECG recording. So this every time I hear this phrase, I'm like, yeah, that's a really good point. Like, why aren't we doing more core leads on patients? Because those two things together can give you a lot of really good information. And all of us are using monitors, so we're going to get a number and a waveform. Those little standalone ones were just a number, which is better than nothing, right? Okay, so this is what your normal capnogram or capnography should look like, right? Nice and square, a little bit of a slope. That phase 1 is the respiratory baseline, okay? Phase 2 is that what we call the expiratory upstroke. Okay, so the beginning of breathing out. Phase 3 is that expiratory plateau. And then where that little star is that peak EtCO2. So that's where it's reading the number that you were seeing on your screen. That's arguably the most important thing that we need to know to remember. That's a big thing that they're going to test for. The National Registry loves that question. Is what does this mean? Like what number or what does this correspond to? It corresponds to the CO2 number that you're seeing on your monitor. And then phase 4 is that inspiratory downstroke. So again, with everything that we do, there's a systematic approach to everything. So is CO2 present? Do you have a waveform, right? This is really helpful in things like cardiac arrest. Do you actually have a waveform? Is there a respiratory baseline? Look at where that baseline is. Is it actually at 0, or are they breath stacking? Is it higher, or is it getting higher? Is there rebreathing? That expiratory upstroke, so that the second part of that graph, I should have put it on here. I didn't think about that. So number 2, going up, is it steep or sloping or prolonged? What does it look like? That expiratory plateau, is it flat? Is it notched? Is it sloping? We're going to talk about what all those things mean. Same thing with that inspiratory downstroke, and then look at the EtCO2 that you're getting, the number, and then just see if it corresponds on your capnograph. So if those numbers are not matching up, there's something wrong with your monitor, and that has happened, right? So make sure you're looking at your number where it corresponds on the line, and some of them you manually have to set up. Like, it won't show the numbers on the side for the capnograph. You guys have, what do you have now for monitors?
Life pack.
LifePak 35?
Yeah, we just got 35s. We haven't switched them out yet. We're still
Okay,
using
I'm
50s.
curious, I'm gonna actually maybe call Mary and see if I can play with one, because I'm curious about the 35. So I don't know about yours.
We're waiting for the mounts for the ambulances.
Oh, okay. So yeah, it depends, like the Zoll, we had to set it up to show the numbers. It just like assumes that you know that the second line is 45. So we set it up that way. Okay, so some definitions. So SpO2 or pulse oximetry measures oxygenation. Okay, so how much oxygen is actually in the blood attached to those little capsule or attached to your red blood cells. And then your EtCO2 is what is actually measuring your ventilation. So you can see how having those two numbers can give you a lot of information about what's going on with your patient.
What's the difference?
What's the difference between
What's it showing us differently?
what do you mean?
Aren't they both showing respiration?
No.
No?
So pulse oximetry is showing your oxygenation.
Okay.
So how the percentage of oxygen that is attached to the red blood cell.
Yeah.
Capnography is measuring your ventilation. Like, how effective is that person breathing in and out? Because remember, ventilation and respiration are two very different things physiologically. They are not the same thing. They're doing different things. You're measuring different things, and this is the difference in the measuring. Yeah, that's a good question. And that's always why I really try to harp home the difference between, and if I had my way, we would do pathology and AEMT like half of this class every day. And I know there are other people in this room that would like that too.
So you could have just stopped breathing, then your SpO2 could still look pretty
Yes.
good for.
Oh, okay.
Yeah,
for
so
a few
that's what we
seconds,
were talking
right?
about. I had a couple, let's see, I think a couple slides ago. Yeah, this one. So that's what this slide is saying. You can have normal ventilation, but you can have poor perfusion. Okay, so something is happening physiologically. You are internal hemorrhaging, external hemorrhaging. That oxygen is getting in, you're ventilating well, but it's not getting into the system. You can have abnormal ventilation, but still have good perfusion for a while, right? It's not gonna last for that long, 5-10 minutes, and then that's gonna start to go down too. So does that make sense now? Okay.
Is a SpO2 I remember a class or something where they said that it's not exactly a real-time reading.
Oh,
It's
so
there's
no.
a delay, right?
There's
I'll
a
give you an
huge-
example. So I had a patient that had a SAD PD. And his pulse oximetry said 98. But as I was looking at that patient, he was going purple, nipple line up. And I was telling the nurse, you need to go get the doctor because that doesn't look right. And I didn't know what I was really seeing. And she's like, but his pulse ox says 98. He's getting enough air. I'm like, but he's turning
He's
purple.
purple.
So that's a perfect example of
Yeah,
the perfusion's going, but the oxygen and the gas exchange is not happening because there's a blockage because of that PE. And he ended up dying. And it wouldn't have made any difference because it was a huge PE that finally it just plotted right there and was
Yeah.
over.
yeah, so that's a great question. Yeah, so that's kind of the big thing that, like the jump from EMT to AEMT to paramedic, like knowing the pathophysiology and like this kind of anatomy and physiology that goes on with this stuff. It's a higher level of thinking, right? And it's skills as well, but you know more now, right? You're gonna know a lot more. So this is what your normal capnograph looks like. Everything is normal. There's a gradual upslope that you're kind of in that normal range. So this is what hyperventilation looks like. It starts kind of slowly and then gets faster and faster and faster and shorter and shorter and shorter with that steady decrease in EtCO2, right? So the waves are getting shorter and they're getting closer together. Causes of this kind of, and this handout will have all this on here. It's kind of a neat little handout. Causes of this are hyperventilation syndrome, things like You guys have one
We got
recently?
a girl whooped by a panic attack, yeah.
60, yeah, her respirator was like 60.
Yeah,
Did you guys do the squeeze your hands?
Yeah,
Slow her down?
yeah,
We did everything. We did a 12 lead, we did glucose, we did everything wrong, so.
She focused some, but like
Yeah.
it was just a struggle to get that.
they're the worst, they're the most difficult patients to deal with, because
We had two patients. They were both having respiratory-ish things, and so we went down a track of like gas or
Yeah,
poison.
because they were in a fifth wheel with a ceramic heater, right, with a propane heater in there, and they also had open paint cans all over this fifth wheel. So there's a strong chemical. It felt like a scenario, like the worst scenario. Chemical fumes, propane heater,
Why were the
enclosed
paint, did you
space.
ask them? Like,
They
why?
were painting apparently.
They were those kind of people. Long story short, they had an STD.
Long story short,
Down
she
the
had
wrong
anxiety
path of
over an
it.
STD.
Yeah,
Yeah.
yeah.
We didn't even know she had a history of anxiety attacks. She didn't reveal that when we asked her medical history until a little bit later. So yeah, I learned a lot about hyperventilation on that call. I mean,
Yeah.
sometimes you gotta do a few things wrong, and then that really sticks better than when you do things right.
The
Oh,
clown.
1000%.
Yeah.
Oh, I can tell you all of the mistakes I've made in the field and all of the things that I have learned from those mistakes.
The clown music was definitely playing.
Oh, yeah, I can totally picture the scene, and it's like South Kalispell, like Lakeside area, so I get
Yeah.
it, like I know where you guys are at.
Right.
So another one is overzealous bagging, right? And I can't believe I didn't change this. So my other soapbox is that we should not be calling bag valve mask ventilation bagging. We should be calling it, you are ventilating that patient. You are not bagging that patient. You were ventilating that patient. And I still catch myself doing it. That's a big thing, like in the Boston area, they're like very much, say it, bagging, we're ventilating patients. And then PE, like kind of just talked about, those big saddle pulmonary embolisms or wherever they may end up. So hypoventilation, this is maybe some sort of obstruction. Super quick side note, I'm such a nerd. We got access as faculty to the New York Times, and Kyle is not as excited about this as me, but I'm getting all the notifications from the New York Times about what's going on in the world, and there's some big stuff going on right now. Lots of things can cause this. Respiratory depression for any reason. Narcotic overdose, CNS dysfunction. We're usually not underventilating patients with a bag valve mask. That very rarely happens. And then things like heavy sedation. So, the things as medics that we need to worry about is giving, way too many benzos and way too many narcotics at the same time. And really kind of tanking that patient's respiratory drive. Apnea, pretty self-explanatory. They're not breathing, so there's no waveform. This allows for instantaneous recognition of potentially fatal things that are happening. So you have a patient who is maybe unconscious and you're monitoring this patient and you see this happen on the graph before you see with your patient, because a lot of times the monitor will alarm you because you have a lot of stuff going on before you realize your patient has stopped breathing. There's a lot of causes. So in a non-intubated patient, it can be respiratory arrest, usually followed by cardiac arrest if it's not fixed pretty quickly, or the equipment is malfunctioning. That happens fairly frequently. So sometimes people will freak out and be like, oh my God, my patient's not breathing, and then look at your patient and they're just fine. These are very sensitive pieces of equipment. So that alveolar plateau, this is a loss of that plateau. So this is the very hallmark shark fins. I'm sure everyone has seen this at one point or another. These are your classic presentations of any person having severe bronchoconstriction. So asthma, COPD, an incomplete airway obstruction, so they're still moving some air, but they have some sort of blockage. Or if you have an intubated patient, that tube got kinked, or it's, you need to suction that tube because there's mucus in it. And in my experience, every time you tube a patient, they have to vomit and they have lots of secretions. So this is usually a problem. So this is poor perfusion, right? You're not really you're getting something, but you're not getting a graph. This is CPR. It's going to tell you your effectiveness of resuscitation efforts. what's that number that we kind of use as the hallmark to these efforts? Does anyone have like you have a CO2 in mind? Where you're like, this patient's probably not gonna have meaningful function.
10.
10, yeah, it's 10, I mean, 10, 20, really, it depends on downtime, right? For those of you that have, if you've taken the art or you haven't taken that art of resuscitation class, there's some really interesting research, that may hit the AHA. Have you taken art yet?
Yeah, that was when you were here. That was like, what, 2 years?
2 years, oh yeah, we took the same class, that's
Yeah,
right.
That's how I,
Oh, that's how, oh my gosh, that's how this all started, I remember. Yeah, so,
took that long to get you hired.
it took me, that's right, it took 2 years. The college is a little slow, with the hiring process. So there's an interesting thing that they talk about in, terms of farming CO2 during a cardiac arrest. So the AHA, and it's very scary. So the AHA says, you know, you see VFib on the monitor and you shock that thing immediately at 200 joules, right? Well, now they're thinking, maybe you have a little bit better chance of getting this patient back if you have a little bit higher CO2. Why would that be? Let's think about that for a minute.
Turn on that drive.
The drive is there. Yeah. Yeah. That drive, the physiological drive to breathe is there. Now it's really hard. We were running scenarios and it is really hard to wait when you're in a VFib arrest to shock that patient when you have a low CO2. And that last patient that I had, granted, he was shocked 3 times before we even got him with an AED. So at that point, it's kind of, you know, you kind of negated the things that we talked about, but, you know, Tommy and I kept looking at each other and we were like, there's VFib, but he's only at 25. Like, we could wait a couple more minutes and see, but we couldn't, you know? And it's just super interesting because we followed the AHA guidelines, so we don't typically like give bicarb anymore in the field, right? We don't typically give calcium in the field. We did give Narcan just in case. And then the first thing they did when we got into the ER, what did they do? Dump them with bicarb and calcium. And I was like, come on, guys, like AHA.
But I think that you're gonna see the bicarb come back.
You think so?
Yeah.
Yeah,
I think it's gonna come back because
Of the
of,
C-
yeah, the CO.
I think you're right.
And what they're trying to find out is maybe we're giving too much epi
I was gonna say too much epi.
to vasoconstrict
Yeah.
and not hitting the chemistry with getting sodium bicarb
Sodium bicarb and
and
calcium.
calcium
Yeah.
at the beginning instead of waiting till, well, we've given everything.
Everything else, let's just.
Well, let's see what happens.
Yeah.
And that's not a logic, that's not a scientific way of figuring out a problem.
Right. And it's hard to not give epi every 2 to 5 minutes either.
Yeah.
Like we pushed it to like, I think we only gave 2 epis by the time we got to the ER. Like every 8 minutes or whatever. And it's hard, like you're just so ingrained, like epi. And it was, I mean, he was in VFib, so we were giving AMI too. So epi, you know, like, yeah. So the new research that's coming out is super interesting. But I think I've mentioned this before. The data shows that once something becomes best practice in the hospital setting, it takes about 10 years for it to hit the field. So it'll be a while before we start seeing this stuff in our systems. Although, you know, Dr. Davis is quite progressive, so we may see some a little bit earlier. But ultimately, at the end of the day, we have to follow AHA because that's law. So.
But if you wanna do something, you wanna deviate a little bit, you can always ask
100%.
and get a doctor's order.
Yeah.
This is what I have, doc. This is what I'd like to do. If it sounds reasonable, most of them will say, sure, go ahead.
I've never had a doc be like, no, don't do that. And for me, it's the pain med thing, right? Like we have very, very conservative pain medication protocols in Flathead County. And everyone has heard me get on the soapbox, but like by the time I get a patient where I'm at, they've been cold and broken for many hours, right? I'm not gonna give 1 milligram of Versed and then wait 5 minutes and give another milligram of Versed and then wait 5 minutes and then give 25 micrograms of fentanyl. I'm just not that mean, right? So I tend to give a little bit more upfront just to get these patients out of pain. And no one said anything to me yet. I'm sure someone's gonna get talked to someday. And this is being recorded, so I'm sure Bryles will see this at some point and be like, oh yeah, we need to talk about that. So this is a beautiful capnogram. This is what happens when you achieve ROSC. There's a delay, right? It's like, it's not real time, so there's a couple second delay. And then we talked about that, less than 10 efforts are pretty, futile at that point. But if you see this dramatic change, it usually means that you have a pulse back. So an elevated baseline, I was talking about this, that breath stacking. This indicates an incomplete inhalation or exhalation for whatever reason. The CO2 in the system is not completely getting washed out, so it's getting higher and higher and higher with every breath that that patient is taking. You see this very commonly in COPDers, and this is what causes, that air trapping is what causes that barrel-chested appearance in these patients. And you can see it on the monitor. And then if you have a patient who is ventilated, this is one of those things where you know immediately that you have a circulatory problem with that ventilator and you need to start manually taking over ventilations for those patients until you fix the ventilator. And then some sort of foreign body aspiration can also cause this in both ventilated and non-ventilated patients. So this is just a list of all the things you should use it for. I'm of the opinion that you should use this on every patient. It's the sixth vital sign. I do understand that it's expensive, right? It is not a cheap piece of equipment. I think each of those, I think we run like $25 to $30 for each end-tidal nasal cannula, as opposed to like 50 cents for the regular cheap nasal cannulas. So, and that's just because of that chemical in there. It is expensive to manufacture. So tube conformation, perfusion, COPD, asthma, anything that you might think that is going on with this patient, you can use capnography for. So I love case studies and I haven't done enough of them. So we are going to go through a couple cases. It's going to be interactive, so I'm not going to do a lot of talking. You're going to do some diagnosing, and we're going to kind of talk through them. So it is 9:45 at night. You have a 65-year-old male complaining of crushing substernal chest pain. He rates the pain at 10 on a scale of 1 to 10. He denies shortness of breath or any other complaints. He has a history of cardiac disease and asthma. So we teach the doorway assessment for pediatrics, right? The pediatric assessment triangle. I think it's a great tool to use on any patient that you have. So from the door, he is anxious and alert. You can see that he is breathing pretty fast, but you don't hear any adventitious sounds, and his color is unremarkable. Okay, so he looks just normal. Okay, so here are his vital signs. So he is a little hypertensive, on the border of tachycardic. He's breathing about 20 times a minute. His EtCO2 is 40. He is 96 on oxygen, and you put him on the cardiac monitor and it shows a sinus tach. Okay, so so this is what you get. What can you deduce about this guy's ventilatory status? If anything.
It looks fairly normal.
Yeah, it looks
Normal numbers are good.
Yeah, so we're early on in whatever is going on with this patient. He called 911 at the right time, okay? So is that EtCO2 that you saw on that screen within normal limits? Yep,
Yes.
okay. Is that waveform normal? I thought I put them on the same slide, but I don't know. Apparently I didn't.
Yeah.
And then we just talked about what you can deduce about this, about this guy's ventilatory status as of right now. So interventions, what do you want to do for this guy?
Aspirin nitro.
Yeah, what do you have to do before you give those things?
Do we have a blood pressure up there?
Yeah, you got a blood pressure, so what's your
Erectile dysfunction.
erectile dysfunction meds? What else?
Maybe.
IV? We've talked about that already in this
12 lead.
class. 12 lead. How about allergies?
Yeah.
Probably should ask about those too.
Right.
Okay. Anything else you want to do?
Call for ALS.
Yeah. Oh yeah. Yep. Call for ALS. Yep.
Which obviously, I mean, there's only so much 12 lead interpretation we can do, but it said it's sinus tach. And so are you still gonna give? I mean, I guess it depends if you have a medic to truly interpret that 12 lead, because we're just gonna give nitro for chest pain.
Right.
But if
Exactly.
it's sinus tach, would a medic still wanna give nitro, or we?
Yeah.
Rolling?
Yeah. We don't. At that point, we don't.
Okay.
Yeah. Cause it hasn't actually said anything about a 12 lead yet, so sinus tach would just imply that you have a 4 lead on. Yeah. Okay, our second case, any questions? That was a really easy case, they're gonna get harder, I promise.
Does that ever make you nervous with nitro, like 130/80? I mean, you can crash them. I know you're over the protocol.
That's what the IV's for.
That's what the IV is for.
Right.
I get more, so 130 is okay. I get more nervous at 120. I won't give it at 120. That's too low for me because I have more times than I would like to think about learned my lesson on tanking those patients.
It's 90.
Yeah.
It's 80.
Now, yeah, I was like, oh, great, okay.
But I was glad I had that IV because now let's give you some fluid.
Let's give you some,
bolus.
yeah,
Right.
yeah.
Maybe we won't give you any more nitro.
In fact, my last STEMI patient on the mountain, my EMT partner had never seen it happen. And his blood pressure started, it was like 160. So he wasn't super hypertensive, but it dropped from one dose of nitro from 160 to 90. It was crazy. And I had got the 12 lead. I recognized, right? I recognized that he was probably having some right-sided stuff going on. And I was like, well, your blood pressure right now is good enough. But it wasn't after one. So I got to really show my EMT who had never seen that before, like, this is why it is so important that you get these things in place before you get nitro. And I'm glad that they recognize that because it used to be back in the day, EMTs were just giving out nitro like candy, spraying it, like there was, you get nitro, like, oh, you have chest pain, you get nitro. Like they weren't asking any of the ED questions, like it was kind of crazy. So, okay, it is 1600. You have a 25-year-old male with a history of asthma. So probably know what this one's gonna look like. He has been compliant with his medications, but today he ran out of his albuterol. He was at a basketball game. He suddenly got shortness of breath. He does not have his albuterol inhaler with him. He is sitting on the bleachers in minor respiratory distress. It is noisy and hard to hear lung sounds. So your doorway appearance, he is alert, anxious, in obvious distress. Work of breathing, his respiratory rate is fast. You can hear wheezes when you are close to the patient, and his color is unremarkable. So what do you want to know about this patient? What are you going to do when you first walk in? You're going to there's a lot of people around. It's really noisy. It's quite chaotic. What are all the things that you're going to do on this scene?
You want to safely move him to somewhere else if possible. But
Yeah. Do you want the basketball game to continue?
If we're
Do
doing
we care?
patient outside, it doesn't matter if they want to keep playing basketball.
Okay.
Yeah, put them in the truck in the hallway or something.
Okay. What else are we going to get right away on these patients?
Vitals.
A full set of vitals.
Full set of vitals. So let's see what they say.
No, I was just saying full set.
Yeah, okay. So 120/76, pulse is 100. He's breathing 14 times a minute. So what if you have a patient who has asthma who's breathing at a normal rate? What is the pathology? What's the problem?
They're not gonna be blown off.
Is it ventilation or respirations? Ventilation or respiration is probably the problem.
Respiration.
Respiration, yeah, because they're ventilating okay,
Right.
right? It said from the doorway, like you can see, they have a little bit increased work of breathing, but they're only breathing 14 times a minute. So it's probably a ventilation problem at this point. And you can confirm that because their SpO2 is dropping, it's 94%, and their EtCO2 is what? It's 50. So you're not yet into that mechanical ventilation problem, you're at the respiratory problem. So that's the beginning of the asthma attack, right? We classify asthma as mild, moderate, and severe, and we will talk about that in a minute. And then cardiac monitor showed sinus tach. We got a 4 lead, and it's just nice sinus, upright P waves. Okay, so look at this one closely. Does this match what you think that the picture of this patient is happening right now? Yeah.
Yeah.
Okay, got
Bronchoconstriction.
bronchoconstriction, you have the shark fins. This one's a little slower, though I couldn't find one that was like a normal respiratory rate. So this one's a little slower, but he was breathing 14 times a minute, so there would be a few more waveforms on here. Just note that. So that EtCO2, it was 50. Is that normal? No, so that's too high. So what's happening?
Breathing off and off.
So he's now starting to breathe too slow, right? So we're kind of moving into that moderate, going to be severe asthma if we don't do something about it now. So we talked about the waveform. What are some other things now as an EMT can you do?
Nebulizer.
Nebulizer. What are we gonna put in that nebulizer? Albuterol. What are things that we need to be considerate of or worried about with albuterol? Tachycardia. Yeah. Anything else? Not really.
I mean, if you heard breath sounds,
SVT.
you heard breath sounds, you'd be wondering if there's any fluid or anything, in which case you might
Right.
lose hypertrophy.
Yeah, so it said you could like audibly hear wheezing,
Right.
but lung sounds were clear.
Yeah.
So. Yeah, nice job. Okay, so interventions, we kind of went through most of them. You're gonna give these patients oxygen, you're gonna give them the albuterol treatment. You're gonna transport them in a position of comfort. Would you ever lie a respiratory patient down flat? No. No, I've never had a respiratory patient that I can remember that's like, I'm more comfortable on my back flat. If you do, those patients are sick. They're not ventilating well. Okay, so just a little summary, right? This is kind of everything we just talked about. Everyone's EPIC certified now, right? Yeah, something we have to be. So that's a big part. CO2 is a big part of the EPIC protocol. I actually just took our EPIC protocol to Boston because they were unfamiliar with that study, which is insane to me. So we're gonna actually start.
Yeah, and the
using it.
hospital doesn't, the hospital looks like it's crazy.
Yeah, the hospital's getting better, but still not, not great. Okay. Gonna take like a quick little break.
Yeah.
And then we will go on to next one. And I'll actually go ahead and just put that, I actually made a PDF of that handout yesterday to put on here and I completely forgot. So. Okay. You see how pretty the lab looks and the office? You haven't been in there yet?
No, not today.
No.
I'll go take a look.
I'll walk over with you because I got drunk. Oh. I forgot how tall you are until I'm standing like right next to you. And I'm like, oh.
Yeah, let's go. Might be moving, see.
Oh, yeah? What happened?
Yeah, put an application for a trailer down Lakeside. We'll see if I.
You have to move or you want to move?
My daughter's mother is like sharing a place.
Yeah.
And I told her I was thinking about moving this summer, and then she wants the trailer that I'm in. Well, she's been real pushy about it ever since, and so.
How much is your rent down in Lakeside if you get it?
Well,
It's actually not too bad. I thought
it's an old trailer and stuff, but I mean, it's still Lakeside, so.
So talking about the meeting, how was the training last night?
The respiratory thing, like.
Did they vote? Did enough people to
Yeah,
vote?
we had just enough to vote, yeah. Yeah, I got in at like.
9:30
Mhm.
last night, so wasn't sure if I was gonna come to class, but I thought, I know I have to work next Thursday, so I thought I really want to come today, so I'm gonna miss next week.
Yeah, I got a Proctor Mary's EMR class next Thursday, so I don't think I'll be here.
Oh, how's that going? Is it almost done?
Yeah, next Thursday.
Pocket Prep app starting yesterday has made me sign in every time I open the app.
Really?
It is driving me crazy.
That's weird. I've never had to re-sign in on the app.
Cause yeah, it was fine.
Did you do an update?
No.
Oh. Yeah, mine's not making me. Did you sign in on like a computer or something?
The only thing I used it on was yesterday morning. I used it, and it was, I'm good, thank you.
Okay. Too sweet?
Yeah, too sweet for me.
Oh. What? Down.
Yeah, base. So bicarb is a base. And the idea is that you're bringing the acidity down. Because patients in arrest are usually giving a lot of.
Because they're not
acidic.
blowing off
You're-
the
they're-
acid
yeah.
with respirations.
Yeah.
Okay.
So as that acid builds up, that's very harmful to the body because our acid base system, when we're too acidotic or too alkalytic, like we have just a very narrow
Mm.
bandwidth that we can sustain life. So if we can reduce that by lowering that acidity, that can help with patients surviving.
Okay.
Yeah.
So it's
No, that's a good question. I
helpful.
didn't explain that.
Okay, so. Because before I didn't have the color capability,
Ah,
the color really makes it a little bit better, so I'll try to pull it up. And then, I'll go.
Thank you.
yeah, if you want to send me the color,
Color.
or just put the color one on canvas too.
Yeah,
Either way, send it to me, I can do it or whatever.
And the V/Q is supposed to represent ventilation versus quality?
It's your ventilation. It's, yes, quality is a good way, yes. So it's your ventilation and your respiration.
Okay.
So and if you get, those numbers are supposed to correlate, yeah, thank you, my brain this morning. I will send you something on it, I'm not very good at explaining it. VQ mismatch is really important when it comes to things like respiratory distress, any sort of cardiac conditions. And it's ventilation and perfusion. It's another way to look at it. And they're not measurable numbers, right? It's more the theory of it,
Right.
and the pathophysiology, but, yeah. I'll pull up some stuff on it. It'll explain it a little better.
I was just trying to make sense of
Yeah.
why it said Q instead of like, I don't know.
It's the Latin, yeah, it's the Latin for it.
Okay, that
Um,
makes sense.
So will most of the COPD stuff with like the emphysema
It would
that.
be too easy to
Pretty
figure out,
much,
you wouldn't need to be an AEMT. if
Right.
you-
Yeah.
They all look pretty similar.
yeah.
A reversal of your normal.
No, those are super. Maybe I might open exit copy. I don't really understand the white chocolate part. Oh no, those are different. I got ones that were like white chocolate and the dark chocolate was too intense. Can't taste.
Those are a little sweet, but a nice little study snack. I'm fine.
I mean, we're just talking about this, like, I know the syllabus kind of gives us, but like.
Yeah, the ones at Costco
when
have
you
like
started the class,
freeze-dried strawberries in them.
you say,
They're super good.
This is week 7, this is what you should have done by now, you should read 3 chapters. I know it's kind of in there, but it's kind of nice to just kind of refresh all that, like, where we should be, where we falling behind.
Oh.
We're on schedule
Yeah, we're.
for the syllabus, yeah.
Have you seen?
No, not you, the students, like, as a student, this is where you should be.
Oh, okay.
you know, Not, I know you guys are. I'm just kidding.
Okay,
So,
so as
You
far
should have
as,
read through, you know, this, because I
Okay.
know I'm falling behind. Sometimes I have to refer back to the syllabus and say, shoot, how far behind? am I
oh,
now?
okay, so introduce, hey, this is week.
By the end of this week, I would
Oh,
like you to
yeah,
have done blah, blah,
yeah.
blah, 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 blah.
Yeah, I mean, it sounds
No,
small,
no.
but it's just like 60 seconds and it I can write it down in here and say, okay, I'm still this far
Module,
behind.
yeah.
What's my
I have to
homework?
look
for
at my
the-
schedule to know where I'm at.
Right,
today.
right.
I
Got a lot
Chasing
going on.
shiny objects.
Right.
Have that. We are, and I have a schedule printed off.
Yeah, actually I do too.
So
And
I can just print one off.
We should do that, yeah.
We would do that. This- Easy, everything snowballs to. We are. National matches.
Yeah,
Earn this shit.
yeah. I have the EMT one on one of my.
Yeah, we all got national EMTs, but there's so many
Oh.
like state A's.
Yeah.
It's like, I'm a national.
Right, right.
The doctor is done.
Yeah.
I
They were
took-
they were all
I learned
grandfathered
this,
in and
yeah.
stuff, yeah.
There's no light duty option. Like you have to give me a note to the union that says I cannot work for 3 to 4 months. You will be off work for 2 weeks. She may return to sedentary duties at 2 weeks. Like, no.
It's another ancient trailer, but it's got a fenced yard and.
More square foot.
Are we?
Wow, we ended
I
up.
think it would be though.
It's got a fence,
Did we skip a
maybe,
week?
maybe
You're in a fifth.
100 square feet.
Yeah.
It's another, just trailer though.
Yeah.
I was a little confused. We might
The
have.
upside is like get a dog.
Oh, yeah.
That's important in life, right?
That's pretty cool.
Did we do that last week?
Is that the one right by the keyboard?
It's on, it's like Burns Road and then the.
I
next one.
thought so. I was like
Right there.
looking at my
It's two
schedule and I was like, this seems really weird. I'm gonna roll with it.
Okay,
Right.
I'm really sorry.
Yeah, no, that's.
We'd lose you for the South Cal.
Or I would just take the.
We just flipped a week.
Yeah.
Hey, Kyle and Amanda,
Yeah.
are you guys talking about where we should be at on the schedule? All I can hear is
We
something
are.
about, I can hear something about trailers and square footage and chocolate and fences. I can't hear what you guys are talking about.
We only BS on the breaks. We don't BS when the glasses off.
Yeah. So I actually skipped a week. We were supposed to do like immunology and toxicology and stuff this week. So
Okay.
thank you for, yeah. I don't know how that happened. So we're just gonna do that one next week. Instead
So
of,
we're gonna flip this week, so we'll do abdominal renal today. And then next week, we'll do toxicology, immunology, and infectious. So,
Can you would you be able to send an email or a message on the message board that we can all see that tells us where we should be at? I mean, I hate to say it, we've been doing this for 7 weeks, but I'm always feeling like I'm not really sure what I need to do from the time class ends today until next week. Like, what should I read and what quizzes should I have done before class? And it's my fault for not, bringing it up sooner.
You looked at the syllabus on Canvas, because it says quiz, what we're going over.
And what I'll do is.
Yeah.
If you go to syllabus.
It's pretty clearly laid out on the syllabus, yeah.
Yeah.
Well, the syllabus says that my test, like when the quizzes are due. Oh, wow.
Did you see this?
Yeah, I'm looking at the syllabus now. I don't know if I have an old copy of the syllabus somewhere. Like I swear when I was looking this morning, it said the quiz 5 was due in June was the last I saw, which didn't make sense, obviously, but.
So if you're talking about being on platinum, they're all set. I think, I just defaulted them to be done at the end of the class.
Oh, okay.
And it's up to you. If you want to take all of your quizzes the last day.
Oh,
fine.
no. Yeah, not at all.
But yeah, this is the syllabus that's been up since day one.
So on like, for example, week 8, I should have exam 2 done before class on the 20th. Yep. Okay.
Yeah, and because we didn't cover that now,
We will push that date.
yeah, we'll push that date after.
Because I wrote that with toxicology, immunology, and infectious in mind. So I will push that date back a couple weeks.
What I'll do is, for those that are tuning in now that are not here presently, is I'll make another announcement just saying that these weeks got mixed, got flipped.
Okay.
And then we're gonna push exam to the end of spring break, because we're gonna meet next week, and then the following week is spring break. So that'll also give you some time to catch up on stuff.
Okay. Thank you for the clarification.
And I think what I'll do moving forward is I'll just pull up the syllabus schedule, and then we'll talk about, hey, this is now week 8, and this is what we're gonna be going over. This is what we're gonna be going over today. And then this is what we'll be going over next week. And just, I think having that is just a helpful reminder. Okay, and then we can move this forward next time for next year. All right, we appreciate the feedback, but even sometimes we make it, so. Okay, any other questions you guys have out there online? Okay. So we're gonna go back, we're gonna start with abdominal and GI disorders. Okay, abdominal GI disorders. So I always think of the GI tract and the abdominal area as Pandora's box. We don't know sometimes exactly what we're going to get into. Somebody says they have abdominal pain. That could be a whole host of different disorders or diseases. But what it requires us to do is to be systematic about us doing our assessment. The sample, OPQRST is really helpful. And then starting to take from a 30,000 foot view of what could possibly be going on in the abdominal area. And then eliminating the obvious and the most common, and then trying our best to narrow down what we think could be going on with our patient when it comes to the abdominal cavity. So we have a lot of different visceral organs in there, the GI tract. All of those can have different symptoms and irregularities that help guide us into determining more closely what's going on with the patient. That's what we're going to go over today. Anatomy, physiology. Unlike the respiratory system, when you look at the chest, we have the lungs and the heart, the esophagus, the trachea. So that's pretty simple. We can narrow those down. We can look at assessing vital signs, and we can determine, are we getting lung sounds? So it's simpler, in my opinion, of differentials of, is it a respiratory problem? Is it a pump problem? But when we start getting into the abdominal area, we've got all those visceral organs and the digestive tract that can all have different problems or indicators if there's an issue with one particular system or multiple systems. So I'm not going to go through all the anatomy and physiology. You guys can read through that. We need to differentiate the differences between hollow organs, solid organs, different regions that those organs are placed in the body. That's really helpful when you're doing your abdominal assessment, is have an idea, if I'm pressing on the upper right or the upper left, what organs or systems are below the surface that could be causing problems or issues. Okay. What are some of the things that we see? What are some of the hollow organs that we have? Okay, stomach, large intestine, small intestine. Okay.
Bladder.
What's that?
Bladder.
Bladder. What are some of the solid organs? Liver, kidneys, pancreas. So you see how that list can get more longer as we're going through trying to differentiate well, which one is being affected. So this could be medical emergency or medical injuries or disease processes actually, versus traumatic injuries and how that affects those same organs and organ systems. Okay, I like to keep everything simple in 4 quadrants. And unless there's a condition, and the patient may be able to tell you this, have you guys ever heard of situs transversus? Do you know what that means? There's a population of people, very small, it's like 1 in a million or whatever, where their organs are actually flip-flopped. Okay, so instead of their stomach being over here, it's actually over here. Their liver is on this side. There's also one that's dexacardia, where the heart is not over here on the left side, but actually it's over on the right side. So if you're to do a 12-lead EKG, you would need to do it and flip it. You would need to flip the leads. If those are rare cases, and that would be something you would talk to your patient. I've had patients say, well, I have some sort of heart thing where it says it's reversed. But then I go, oh, okay. And I've actually seen the x-ray. We actually had the trauma surgeon come in. When they do x-rays, they put an R so you know which way it is right way because it's transparent. You can flip it. This was before we had digital x-rays. And he flipped the x-ray around thinking the radiology tech put it up backwards. But when we looked at it, the R was reversed. And they were like, hey, wait a minute, his heart is actually the opposite. And so we simply had to flip that around. That would be something you'd ask your patient. Okay, so as far as orientation, we're going to assume most patients you're going to run across don't have situs transversus. Or rather, everything is in this anatomical position based on those quadrants.
So in a patient with that, would they also present strokes more likely on the right side than the left, or is it
No.
just their organs?
Just their organs are flipped.
It's not everything.
And sometimes it's just all the organs, or it's just the heart.
Okay.
So the heart doesn't necessarily correlate with all the organs being situs transversus. So they would have, if they did, it would be situs transversus and dexacardia. So just, that's a zebra out there. Okay, don't go looking for it. But if your patient tells you something, hey, my organs seem to be on the other side, then you go, oh, I know what that is. What was that called? They said situs something or other. Okay, so we're going to assume all of our patients don't have these rare phenomena. And so we think of, when we're making those assessments, we need to think about behind that layer of tissue and muscle, we got to think about our liver is over here on what side?
What's that?
Left
Right
side. Which one?
Right side.
Okay.
There's a little on the left side, but it's mostly
Okay.
upper right.
Yeah, okay, so you gotta sometimes orientate yourself and then orientate it with the patient, because it's the patient's right? Right? Okay, and same thing with the lower left and lower right, so I'll leave this diagram here, you guys can study it, but have a general idea. So if there is a problem or pain or some sort of issue going on, you're kind of thinking through those layers of tissue, what is behind that surface? Okay, blood supply. We've got a lot of blood supply down there, especially with the GI tract. Why is that set up that way? Why is
That's where you're getting nutrients out of your.
yeah, so it's drawing all that nutrients from the digestive system, okay? And it's funneling blood and nutrients to those organs too. So if we do have trauma, or we have a dissection, or we have a disruption in that blood flow, there's a lot of space also where if there is a rupture, for that blood to hide. If we have a large bruising up here on the arms or legs, generally we're going to see it underneath the surface of the skin, right? Or we're going to see it spilling out onto the ground or onto the table. But blood can get trapped and fluid, and the abdomen just gets bigger and bigger. It can hide it, so it can be deceptive. But there are symptoms that we can see. It can help us determine that. Okay. Assessment and management. So here's just a quick breakdown, and you guys can look at this chart. And I would just use it with that anatomy chart if you're just trying to help visualize it, because I'm a visual learner, so I like to have visual representation of what I'm looking at, and then it helps me to remember when I'm doing that assessment. Upper right liver gallbladder. Okay, sources of referred pain. This is where OPQRST is really important. Now, is OPQRST always something we have to cover when we're talking to our patients? Sometimes it's not as relevant, but when we're trying to diagnose things, especially pain, that's where OPQRST comes into play. So do you see pleural, pleuritis, right cavity? So that referred pain, is that pain radiating? Epigastric region, stomach and pancreas. Appendix, AML, what's that? Right here.
Acute myocardial
Oh,
infarction.
okay, yeah, I'm just not used to seeing it like that.
No,
That's fine.
I know I messed up because the old schedule, we
Had
had
it.
it split. And I have the old schedule printed.
Oh, that's
Remember?
okay. Yeah, because we can't give it to you, yeah. Okay.
Yeah, because I really wanted to teach those three,
Yes,
and I marked it this week. It all makes sense now.
okay, that's,
I mean, I can still do all that.
okay.
Yeah,
We'll
we'll fix it.
Yeah. Upper left quadrant spleen, part of the pancreas, pneumonia, pleuritis, left lower cavities where you can have that pain. Epigastric, oh, I know why. I don't know why I was drawing blank, am I? So epigastric region. What do people typically who have epigastric region chest pain, what do they sometimes think if they're not having an MI?
Heartburn.
Heartburn, because that's where it happens. But that can also be cardiovascular and not abdominal. Now, all the brain cells are starting to fire. Okay. The umbilical region, small intestine, large intestine, aorta, urinary bladder, reproductive organs for female, uterus, bowel obstruction, or appendicitis. You can have that pain in the umbilical area. Right lower quadrant appendix, ascending colon, right and left fallopian tubes or right fallopian tubes, ovaries. And then left, we got descending colon, diverticula. This is associated with the descending fold. So if somebody has diverticulitis, you may notice some of that pain in that area. So this is just to help you differentiate when you're doing that abdominal assessment, to guide you in, these could be problems with these systems. Okay, so scene size up. Again, on scene safe, chief complaint, level of responsiveness, we go through all of that, scene color, get a set of vitals. And now we're going to check our patient, okay? And when we've got somebody with abdominal pain, what type of abdominal pains have you guys come across? What does the patient usually present with?
Sometimes sharp pain,
Sharp pain, okay.
throbbing, sometimes.
Throbbing,
they'll
dull,
feel really
acute,
wounded.
yeah.
Acute. They have a history of diverticulitis. They have, I'm not sure, could it just be as simple as gas? Okay, so it could be something simple as gas, it could be an appendicitis or something even more, wrong with them. So what would be some of the things that we'd want to ask when we're talking to that patient?
On the sample history, I like to do last in, last out. So
Yeah,
like
yeah.
When did you
So,
have the bowel movement?
yeah.
That's too.
Okay, can we listen to bowel sounds? Good.
Yeah.
Okay. Medical history. Have you had, what's the big one? What are the big ones for history that we'd want to know? Make it simple. Have you had this before? Have you had this before? Surgery. Okay, so if somebody's had any abdominal surgery, that's a red flag. Could be scar tissue, especially in the intestines, the digestive tract. It could be secondary infection. It's now starting to occur.
Appendectomy can
Appendectomy.
rule that out. It's
Yeah.
just,
Right? And what else? What are the things that can bother people?
Gallbladder,
Gallbladder. Like,
gallstones.
have you done anything for this abdominal pain? Are you being currently treated for this abdominal pain? Does this feel like a similar incident you had in the past where you had to go to the hospital? Especially those with diverticulitis. Yes, this feels like an episode, which is that inflammation of the GI tract. Okay, so those are things we're going to look at. Then we're going to look at skin color. We're going to look at making that assessment. Sample, OPQRST, helping us further dive into getting some more symptoms that then we can present when we take them to the hospital. Okay, liver. How important is our liver?
Very helpful.
Yeah, okay, it does a lot of different functions. I call it the wonder organ of the body because its ability to remove toxins, its way to process medication. It's like it filters out things that are harmful. It grows and adapts based on its physiology. And it's very resilient, so it can take a lot of abuse. Okay, but when we abuse that liver and it starts to degrade or have issues and fall apart, it can be a pretty serious, especially for that patient. It can also affect other organ systems that have to try to take up the slack if the liver is not able to do its job. Okay, so if we all seen patients that have that jaundice look to them, the yellow and the sclera of the eyes, they usually have a large abdomen because their liver will actually enlarge. It's real fatty, okay? And they have less energy, flu-like symptoms. Hepatitis can affect the liver and attack it. There's a lot of things that can go wrong with the liver. And that's where we're getting that information from that patient to determine if they have any sort of liver disease. Tumors can also affect it. Okay, gallbladder. What's our gallbladder good for? What's the primary job? Is it essential in digesting foods?
Yeah.
Okay, what kind of foods?
Fatty food.
Yeah, all that fatty stuff we like to eat. So that the enzymes are the things that help break down food is what is bile, gets introduced into the digestive tract, and it helps our body process and break down those fatty and proteins in the system, so that our body can then draw nutrients from it and nourish the rest of the body. Okay, but if we have problems with the gallbladder, that's going to cause pain, right upper quadrant pain that radiates to the right shoulder, scapula, or back. So this is where we use that OPQRST in getting, does that pain go anywhere that you're having? Yeah, I got this right shoulder pain. It's it really is bothering. Doesn't necessarily mean that it's something with the gallbladder, but these are some of the symptoms. So that's why it's important to really use OPQRST to help narrow down where's that abdominal pain coming from, or where's that referred pain going to. Stomach. Okay, what does our stomach primarily do? Simple terms. So we chew up our food, we swallow it, it gets down into the stomach, and what's in the stomach? Acids, yeah. And there's rugi and there's folds. And so now with this chewed up content we've used is now going to mix with those acids to help further start breaking down those compounds and allowing that to go, it creates like a slurry. And that is what's going to go through all the small intestine as it goes down. Can we have problems with the stomach? What would be a problem you guys have encountered?
Ulcers.
Ulcers, okay? So some of them, there's a rupture in that lining. It's gonna be very painful after, especially if they eat foods. Some spicy foods or more acidic foods can be a problem. What causes those?
Alcoholism.
Potentially, okay, that's a wearing down that liner, okay? But there's also bacteria that can also cause ulcers to form. And so a lot of people, what do they do if they have ulcers? To self-medicate or to take care of them.
Take, Tums.
Yeah, Tums and acids, why? Because it's very acidic, they're trying to neutralize that acid, get relief. And that may work, if you have a meal and your stomach is a little bit upset by it. Taking an antacid is just helping to balance out that acid. But if it's a chronic problem and that ulcer is there, what can that ulcer do as it starts to progress? It can break down that lining and it gets really painful. It can even start to bleed, and you can have bleeding ulcers. And those are not fun. And those need to be treated and taken care of because they're probably not going to heal on their own just taking antacids. So it could be a bacteria. So they have prescribed some people, depending on the type of ulcers they have, antibiotics to help heal that infection, or they may have to use other treatments to try to help resolve that issue. Okay, but also keep in mind that what mimics and can be dangerous is that mimicking of that antacid or that acid reflux can also mimic some of the symptoms we might see with cardiac. So how would we differentiate between epigastric pain that is cardiac versus maybe it is stomach acid or ulcers? What would we use to differentiate that? What's that?
12 lead?
2 and 12 lead, sure. Can we put that up there, see if they're having a STEMI? Yeah, that's a quick, easy way to figure it out. What's another thing? What?
History.
History.
They know they have a history of
Yeah,
ulcers.
yeah.
Or did it-
Can they have both?
Yeah.
Possibly. Well, what else would we notice if it was stomach ulcers? We're going through OPQRST, we're asking them questions about when was the last time you ate? When do you think a stomach ulcer is going to kind of flare up?
Probably that same time.
Probably not too long after they had a meal, right?
Changes to consistency of stool and stuff.
Yeah, so if you have a bleeding ulcer, yeah. Do you have dark, sticky stool? That might be another indicator. Are you currently taking any medications to treat that ulcer? So you can use some of those differentials to go, I'm leaning more towards it's more epigastric. Well, this seems more cardiac. I was exercising or I was, doing some physical work. When was the last time you ate? 6 hours ago? You see how you could use that and go, well, that's maybe it's more cardiac than it is GI or the stomach. So that's what I want you guys to be thinking about as AEMTs, is using that questioning is really helping you differentiate between cardiac or maybe this is epigastric or this stomach related or GI related. Okay, pancreas. What's our pancreas useful for?
Insulin.
Insulin, yeah. And did we already talk about insulin?
Yeah.
Yeah, we've already gone through that. Sometimes I forget where I'm at. But what if we're having problems with the pancreas? Pancreatitis, or if somebody has a cancer in the pancreas, that can cause a lot of pain. So you might see left upper quadrant pain that refers to the left shoulder. So what was the gallbladder? Right shoulder. Pancreas, left shoulder. So now see how you can use that differential and go, well, that might be gallbladder, but that's going to the left is pancreas, right is gallbladder. That's what I want you guys to think about when you're doing those questions. It may help. It doesn't necessarily mean it is, but these are some symptoms we might be able to see, okay? You might, ask more questions if they have diabetes or if they have other issues or if they've had other pancreatic issues. Okay, the spleen. Okay, what does our spleen do? Okay, filters blood. Can you live without your spleen? Yeah, you can. You can have it removed. But what really is harmful if you rupture your spleen?
Bleeding.
Yeah, a lot of bleeding. You can trauma, but it's well protected under this rib cage, but it could still rupture. It could still have a lot of issues. Sudden intense pain subsides, then intensifies, may be accompanied by syncope or orthostatic hypotension. Do you guys know how to do orthostatics? Okay, so how do we do orthostatics?
Yeah.
Vitals while they're sitting, vitals again while they're standing shortly after.
Yeah, so laying down, sitting up, and then standing up. And what are we gonna be looking for? Somebody is positive for orthostatics, what does that tell you?
They drop in hypertension.
Yeah, so their blood pressure is gonna drop, their heart rate's gonna increase. For people that are truly hypotensive, that are gonna show that orthostatic change, they're laying down and they feel dizzy, and I sit them up, and they get real flush and pale, that's telling me I'm not gonna need to stand them up. But I've had some people, oh yeah, I feel a little dizzy, and I give them about 2-3 minutes. Okay, so the heart should recognize the elevation, start pumping more blood to the brain. And then I go, okay, let's stand you up. And I will tell you, you have got to be very mindful if you're doing orthostatics, you're doing it for a reason, is 2 people or 1 person really holding underneath their arm and making sure if they decide to pass out because they are hypotensive, that you've got them so that you can sit them back down or lay them down. Because what they'll end up doing is if you tell them just to stand up while I'm taking their blood pressure and nobody's holding on, they're gonna find that end table of the coffee table and smack their head, split it open. From experience, I can tell you that's not the way to find out if somebody's orthostatic or not, okay? So make sure you're holding on to it, okay? Also inflammation in the bowels, you might have crampy, colicky pain, possible vomiting, diarrhea, or dehydration, okay, as other symptoms if the spleen is not functioning well. Okay, large and small intestines. What's the difference between our small intestines and our large intestines in their role? What do the small intestines do? What's their primary job? Just said it earlier. Pulling all the nutrients out. That's why there's 33 feet or whatever of small intestine lines around. Because that slurry that now has all those digestive enzymes is making its slow way around, and the body is absorbing all that nutrients that it can. And what's ever left over, it's going into the large intestine. And what is the large intestine? I think of it as the compactor. Okay, so all that slurry is getting put into the large intestine, and then the body's drawing the moisture. Okay, should be. Okay, and then once it reaches capacity, it's then going to pass whatever waste is left, and where it's going to be excreted. Okay, but what can happen? What problems can we have in that process? You guys have come across
Obstruction.
obstruction. Okay, so something gets lodged in there.
Inflammation.
Swelling. What about food poisoning or toxins that get into the body that are ingested? How many of you like to have diarrhea? Okay, I don't. I don't know of anybody else who likes to. But sometimes our body is also trying to get rid of toxins in the system, in the GI system. But I've run into this a number of times where people have immediately they get some sort of a loose stool or diarrhea. What do they take? Pepto-Bismol. What is Pepto-Bismol gonna do? It's gonna suspend the movement of that intestine. So what is all that toxin that the body's saying, I need to get rid of this? That's why it's trying to. Now it can't do anything, it's paralyzed. Now that toxin sits in the intestines and starts to break down the wall of the intestine. And then patients end up having a much more serious problem other than just the discomfort of diarrhea. So I always emphasize that if your body has diarrhea, let's figure out, we don't want prolonged diarrhea, because what does prolonged diarrhea do?
Dehydration.
Dehydration. So that's definitely a problem that we don't want to run into. But having 1 or 2 loose stools isn't going to create dehydration that quickly. So it's recommended, if your body is experiencing that, it's probably trying to get rid of something it doesn't like. So let it all get out. Okay. Then when you have nothing left in your GI tract and you're still having the squirts, then we do need to worry about dehydration, because you can lose a lot of volume that way. And then if you need Pepto-Bismol, take that after everything. There's nothing more to go. That can help slow down that digestive tract, and then hopefully the body can recruit. But it could also be something more serious, and if it continues, you need to go see a doctor and get that treated. Because I've had patients literally, their gut has rotted, and they've had to go in and now remove sections of their bowel because that toxin was in there for a prolonged period of time and couldn't get out because they were just taking Pepto-Bismol because they didn't want to have diarrhea. Another one is with large intestine is impaction. Okay, so when we're talking about bowels, when was the last time you had a poop? Okay, so what should it be? Let's define. What is a, I know we're getting a little bit gross here, but what should a normal poop be like? Should be brown in color. Okay? Solid, but not so hard that you can't push it out either. So dry where all that moisture's out. So when I ask my patients those questions, I want to ask them things that, what color was your stool? What was the consistency? If they're having a hard time. When was the last time you had a complete bowel? Like, do you have small poops, multiple? How many times do you poop during the day? Or I've had some patients say, I haven't pooped in 5 days or a week. Was that healthy for the GI tract? No. So as that fecal matter is inside the large intestine, it's moisture is being drawn out, more and more moisture, and then it can start to get drier and drier and harder and more compact. And so even as you're trying to push that fecal matter out, it gets stuck, and that's where you get that obstruction. Then that backlogs into the small intestine. And so what do they do if you've got an impacted bowel? Just go, well, just wait longer. What do the nurses do? What do they do at the hospital? Don't know? Have you guys ever heard of an enema?
No.
Okay. Thankfully, that's why I'm not a nurse. No disrespect to nurses, but they have to do an enema. What does the enema do though?
Softens it up.
Well, it helps to start softening up the stool so that if it's dried out enough and it can't push out, then it'll break it down and hopefully it'll be able to loosen it up enough to be able to get rid of all of that compacted bowel. What if the enema doesn't work? What happens? You just give up and go, well, sucks to be you. We gave you an enema, didn't work.
There's medications that can give them.
Okay, there's medications that can also be stool softeners. What are things that can make the shut your GI tract? Painkillers, another one. So if you're on any of those opiates, they always say take some laxatives because it will slow down your GI tract and you could get impacted. Okay, but if that doesn't work, the enema doesn't work, then they have to take them to surgery. Okay, and they may have to remove a section of the bowel because it gets so engrossed and compacted that there's no way to remove that. Okay, what's another problem that we may find too? People that have really hard stools that they're pushing too hard.
Hemorrhoids.
Hemorrhoids. Do they bleed?
Yeah.
They can if they get ruptured. okay? And they're basically on the end of the anus or right around there, they are, look like blood clots that are underneath the skin, okay? If they're continuously there, who are people that are more susceptible to that? People that have to strain real hard, okay? Pregnancy can also
Stress.
increase that. What's that?
Stress.
Stress can also do that. Okay, so those are some questions I'd want to ask. If a hemorrhoid ruptures, could that be deadly?
Sure. leave it.
Maybe, okay, what if the patient's on blood thinners?
Yeah.
Okay, then that could be a real big problem. Okay, there are also things that can happen where people insert things into the rectum that can cause trauma or injury. Okay, so those are other things we need to keep in mindful. And people probably don't want to share that information with everyone. Okay, seen some pretty interesting x-rays. And if there is something that's trapped in the rectal vault, you will not be able to pull it out. Because it creates a negative pressure and sucks whatever that thing is into past the rectal vault into the large intestine. The only way that it's going to be removed is surgery. Okay, and I've heard some very interesting stories of how that happened. Sitting on the couch naked. I don't sit on my couch naked, but I guess if I did, I probably feel something. So what I do is I be respectful. They obviously know this is embarrassing, whatever has happened. And I'm not trying to pry or make fun of them, but I just need to know, hey, is there something that is in there? Okay, what is it? Because I need to let the staff at the hospital know, and then we know that there's an obstruction in the bowels, okay? So be mindful that HIPAA becomes very important. Try not to share that information, even though it is good, water, what is it, water station talk, just remember HIPAA. Okay,
Another big important thing on that would be like the vagal,
yeah,
would be
vagal.
vagaling down and passing out on the toilet. You see that a lot.
Yep, and then you end up in cardiac arrest, and that's because it lowers that heart rate. Yeah, absolutely. Okay, abdominal aorta. Okay, what can happen there? Triple A. Okay, if it ruptures while you guys are on scene or has ruptured prior to your arrival, chances of survival is 0.0001. Okay, if it's a significant tear. But if we're able to recognize those symptoms, so intense ripping or tearing pain in the lower back or abdomen, may radiate to one or both legs. The lower extremities, there hypotension, shock, feeling of impending doom. That's the one that I see the most, is they go, I think I'm gonna die. So I'm gonna just assume it's the worst, and how are we gonna be able to differentiate that with palpating? Yeah, you may feel that pulse, okay? And what's going on is there's a balloon that aorta is stretched, and any sort of extra pressure or tension could cause that to rupture. If it ruptures, your patient is gonna die.
So should we?
If they're able to, so you gotta move them carefully. Don't have them walk. Put them on the gurney. Keep them calm. We don't wanna raise that blood pressure, because we don't know where that threshold is of that lining finally separating and then rupturing. Get them to the ER. They're gonna do a CT angio. They're gonna see, whoa, this person has a giant, looks like an aneurysm, and we need to rush them to surgery. They can put in this, there's different types of it's basically a long stent that's big, and then it helps to secure that airway, or that, not the airway, secure the aorta. And then they're able to either drain or allow the body to absorb that wherever that bulge is. Kidneys. Kidneys are another important thing. 50 gallons of blood per day. Okay, it's filtering. So it's another way of balancing your electrolytes. Kidneys are very vascular. Can you live without your kidneys? One, yeah, that's why we have two.
Go to dialysis.
You gotta go to dialysis. okay, or you have a decrease in kidney function. Okay, so if I have somebody that has kidney issues, what else am I gonna see? You could. Well, what else would we see if somebody has poor kidney function? What are they gonna tell you? What are we gonna notice?
Like jaundice or is that the word?
Yeah, do you know how they get that uric smell to them? They may be doing dialysis, so what else are we gonna see if somebody is doing dialysis? Or fistula, never do our blood pressure on that arm, okay? The other questions we're gonna wanna ask is, how often do you go to dialysis? Yeah, when was the last time? These patients also have other chronic diseases because the kidneys aren't working. The other parts of the body are trying to compensate for that kidney not being as proficient in its job. You guys know where your dialysis centers are in your community? If you don't, you will, because when do they usually call? Right around 6 o'clock, isn't it? Or they're closing, but right when the beginning of, it was always like at the beginning of when they got their patients in to start their dialysis. And what do the nurses do there? Hey, this patient's having chest pain. This patient is, their blood pressure is low. The patient's going to be exhibiting symptoms. They don't feel great on even on a good day. They generally are more tired, the chronic fatigue. But if they have chest pain, their protocol is call 911. And there's usually a stack file this big with each of those patients. Okay. And key things we want to find out is, when was the last time you had a successful donation, or not donation, but dialysis session? How far along are you in your dialysis when 911 was called? So if it's at the beginning or halfway or almost done, those are important because we want to tell the hospital, the patient's in dialysis, this was their last dialysis that they had, and this is where they were in their dialysis when we arrived and took them off of dialysis. And then they're gonna pass that on to the dialysis nurse, they're gonna bring down the dialysis machine in the ER, and they're gonna continue that treatment. However, if this patient is already fatigued or hasn't had dialysis in a while, what is that gonna do? What's gonna raise the possibility of? They have not gone to dialysis in 2 days, 3 days. What's happening inside the body?
Toxins are building up.
Yeah, and it's gonna put them at risk for cardiac seizure, coma, death, cardiac arrest. So those are sick patients, just even on a good day. So when they aren't getting their dialysis, I even have people that have, I just stopped going, I just don't want to do it anymore. So now what does that lead to? That's suicide, basically. People want to give up. They're tired of going to dialysis. They're tired of feeling that way. So if your patient is also psychologically having a hard time just giving up on life, that's something we need to pass on to the nurse, okay, to try to help them out. And people do stop going to dialysis and they end up dying, okay? Ureters, okay, so the urinary system. How many of you guys, can you recognize UTIs? What are some of the characteristics that you're gonna see?
Anal urination.
Anal urination, fever.
Pain.
Okay. What about that foul, rancid urine smell? Okay. Typically, who are more susceptible to UTIs?
Older folks.
Okay, older, right? Because they're not, maybe the hygiene isn't as well. They're also, their immune system may be not quite there. Who else? Females are more susceptible just because there's a shorter path from the urethra to the bladder, so it's easier for pathogens. And what about the people that have Foley catheters? Now we've created a direct conduit from the outside world into the internal world. And so those that aren't having their Foleys changed and cleaned and sanitized, those are also at a higher risk for developing UTIs. Okay. Can you die from a UTI? Yeah. Yeah, you can, because you can get septic and die from that. Okay, kidney stones. How many of you run on patients that are having kidney stones? Any of you had kidney stones?
I've had them years ago.
Yeah.
What's the best med to give or ask for? for kidney stone. Toradol, actually, yeah. I give Toradol to all of my kidney stone patients. Opiates don't actually work that well on them.
So kidney stones, what are gonna be some of the things that we're gonna notice?
Lung pain.
Okay, flank pain, maybe blood in their urine, because it, depending on where that kidney stone, if it's dislodged, it's gonna tear up. There's different types and sizes of kidney stones.
These patients are very recognizable.
And
I have a high pain tolerance and I started vomiting.
Yeah.
Just-
I can tell a kidney stone, when I was working up in Cabinet Peaks, like, I could tell a kidney stone when they were walking in the door.
Yeah.
And most of the time we were right.
Yeah.
Like, they are very, very,
buckled over, they're usually, I mean, you can't get them to stand up
Can't
straight.
sit still.
for
Yeah.
men, it
Agitated,
is, like, they
they're
look like they're in
sweaty.
labor.
Yeah.
Yeah.
And it is very, very uncomfortable for those patients. So key things, you know, in an IV, pain management, if you can, just to calm them down, to get them to get some relief. It's not gonna take all the pain away, but it will. So using Toradol is definitely helpful. Okay. Assessment and management. I've already talked about that. Okay. The abdominal pain. So here's some different, you know, once again, this is just looking at, if you were to look at the pain, where it is and where it's exhibiting across the body. Like we had already discussed, this is just a visual diagram of where you can assess, or when asking more specific questions, going through open fluorescein of differentiating, where's that pain go? Esophageal varices. Okay, what typically happens with esophageal varices? What have been your experiences?
Aspirating blood.
Yeah. And it's usually quite a bit, especially if it ruptures, okay? So it's that inside of the esophagus, those blood vessels get close to the surface of the tissue there in the esophagus, and they can rupture. And if they rupture and start bleeding, what happens? Where does that blood go? Either goes into the stomach, and then they may have dark, you know, coffee ground stool, or they may cough it up or vomit. And depending on where it is in that path, which one's closer, that's where that blood's gonna go. But I've had patients die from esophageal varices because I have multiple places where it ruptures. And can we go in and put 4x4s and stop the bleeding? So how do we stop the bleeding?
Or it's like cauterized or something in the hospital.
Yeah, so they're gonna have to go there, the endocrinologist, or not the endocrinologist, the GI doctor. They're gonna scope the patient, they're gonna see where it is. They can put these little bands that you, like for your braces, like really small ones. They put those on there and clamp it off, try to stop the bleeding. Those bands can break, okay, but they're trying to buy time.
So there's some really interesting research, and they've been doing it in the UK for a long time. Nebulized TXA in the field.
Really?
Yeah, I'll send you, it is
Nebulized TXA.
pretty incredible for these.
Wow. Well, that would make sense.
It's crazy. I still, in fact, Bryles, Abby Miller and I sent this like article to him, and he was like,
Huh,
like, he's thinking about it.
yeah.
It's incredible. Like, it saves, because these patients can bleed out pretty quickly.
Yeah.
It saves a lot of lives. Like, the study is pretty remarkable.
And that's brilliant. Think about
Yeah,
that,
yeah.
because you're atomizing it, getting it down into
You're right to the source.
You're right to the source, stop the bleeding, so you don't have to wait to get back. Because if they are
Yeah.
bleeding, you're not gonna stop that bleeding. You've gotta drive faster, try to stabilize their blood pressure, give them fluids.
Yeah.
They need blood transfusion if
They
they've
need
lost a
blood,
lot
yeah.
of blood, and they need to go to surgery and they need to try to resolve that, okay? So something we need to really be careful of, okay? If they have a history of it, you know, we need to be aware of it, okay? Talked about that, okay. High mortality rate, 30 to 50%. And I tend to see this associated with more of the patients that are heavy drinkers or chronic alcoholics. You seen it with any other population? I haven't really, unless they have some weird disorder. or
Yeah, unless they have pathology, it's usually alcoholism.
Yeah. Cause it's just tearing up. that
Or
blood.
like that, the Mallory Weiss tear is the alcohol one. There is one that is like they have They're born with different anatomy.
And so they're more susceptible.
They're more susceptible, but they're usually well aware of it and they're being treated for it. So,
But this is one of those that can be deceptive when you walk in, they're not feeling well, okay, are they sick, are they feeling great? And then sometimes I've seen the poltergeist like vomit just, and it's like, whoa, the PPE, and these patients can deteriorate very quickly. It's really been bleeding for a while. And because it can leak and leak and leak and leak, and then finally there's a major rupture or multiple ruptures. Okay, appendix. Okay, we all know what that looks like. What are some of the things we're gonna see? Somebody's got appendicitis.
Rebound tenderness.
Okay, rebound tenderness, and which side?
Right.
Right, lower right. Yep. And what is appendix? What's the risk?
Rupture, sepsis.
Sepsis. And yeah, rupture. So all of that foul content that's in there, that's enclosed, is it gonna go into the abdominal cavity and spread throughout if it's not treated and taken care of? So good, roommate of mine, his wife, they misdiagnosed that she had a ruptured appendix. They couldn't see it when they did the CT because it had already ruptured. So it didn't show up on the imaging. So then she just kept getting sicker and sicker, and everything kept saying, I think this is an appendicitis. I think, you know, and they're like, nah, it's just send her home. It's just abdominal pain or cramping or whatever. And finally came back. She was just really pale, not feeling well. They went in, they looked and went, oh, it already ruptured like a day ago. And they ended up going in and having to do surgery. Took her a long time to recover because all of her abdominal area was full of that pus and it was getting worse. So it is very dangerous and people die.
And that happened to my sister-in-law right after childbirth too, like,
well, that's actually more common than you think.
because they misdiagnosed it, they think
Yeah.
it's some.
Yeah.
Something
related to
childbirth related, yeah.
And hers ruptured also.
Yeah.
So it's sometimes very difficult, even for the experts, to know what is actually going on when somebody says, I have abdominal pain. It's just a blanket term that could mean a whole lot of things. Okay, pancreatitis is that inflammation of the pancreas. There's gray turners and there's colon signs. So this is where you can differentiate between the two. Flanks sides of the abdomen where that Turner sign, where you're gonna see that or feel it. Usually develops within 24 to 48 hours. Paul's Turner sign is the peritoneal umbilical area around the belly button. You may notice herniation, or you may, isn't it bruising too?
Mm-hmm.
Where you'll see that around the belly button.
I have pictures of it.
Oh, nice. Liver disease. Okay, we've already talked a little bit about that. Fatty livers, liver that's failing. Okay, so what are some of the symptoms that we're going to see? We've already talked a little bit about that, but liver failure will have right upper quadrant pain, nausea, fever, that jaundice look. It can also lead to esophageal varices. Cholecystitis. This is from the gallstones. Anybody ever had gallstones or know what that does? So instead of that bile being able to get into the digestive system, it creates these little calcified stones, and they get stuck in the bile duct right up here. Those could be very painful or somewhere along that process. Severe pain, abdominal pain, IVs, supportive care. They're really going to have to go in and they'll have to either dissolve or break down those stones to be able to open that up. Yeah.
Is it tough to differentiate between kidney stones and gallstones?
Yeah, it's going to be painful.
I'm gonna say no, because the kidney stones, they usually, in my experience, they're complaining of like a tearing pain, and this is more of a colicky pain. Does that make sense? Like it's more like achy, like, oh, I just have a stomach ache. It's not sharp. The kidney stones are like extremely sharp, like
And they're
tearing,
usually in a fetal position.
and they're usually, yeah,
Right.
This can also, like, when was the last time you ate? Because remember that bile's trying to get out there, and then that's when that stone could kind of wedge or narrow and cause that pain.
And people also walk around with gallstones a lot more frequently than kidney stones.
Yeah. You're not gonna find anybody walking around
With a kidney stone that's not doing, doing well.
But once
That's a
again,
great question, though.
these are
Glad you asked that.
differentials that they're gonna have to make in the hospital. But the difference between kidney and gall is that's how I would look at it. Okay, other causes, pneumonia. Obviously, myocardial infarction or chest pain could cause that if it's cardiac. Spleen, if it ruptures, you're gonna have hemorrhaging. Kidney infections, you can get kidney, well, that could be with kidney stones. Aortic aneurysms, aortic dissections. So when I look at abdominal pain, I want to just think about where is that pain? OPQRST is a great way to help you start narrowing down where the pain is, where is it referring to, so that you're giving this presentation to the ER staff, because they're going to do more diagnostic tests to try to narrow down specifically what's going on. So they'll do blood work, they'll do CT and, X-rays, and they may be able to differentiate more specifically what's going on. Oftentimes, there's not a lot we can do other than supportive care and then just doing a detailed assessment of that patient and then presenting it and letting them decide what they want to do. And then if in, cases like kidney stones, some pain management. But generally, if it's abdominal pain, I'm not going to give pain meds because I want the surgeon to be able to, or the doctor to be able to also do that assessment. Because if I take away all that abdominal pain with giving them some pain meds, they're going to go, I feel fine. Surgeon's going to go, no pain here? Nope, good. Send them home, and then that pain med wears off, and then they're back at the hospital. So you got to be very careful about giving pain meds to abdominal pain. Okay. The only time I do that is really for like kidney stones. Okay, because I want them to do their assessment and not let the pain meds mask. Okay, but follow your protocols as far as it comes to abdominal pain. Okay, that's it.
Yeah.
Then
You have one more.
one more.
I'll try to be fast.
Okay.
It is already noon.
Yep, it is. All right.
You want to take a quick break or do we go?
You guys want to take a quick 5-minute break? Okay, 5-minute break. We'll come back. We'll knock it out.
How much time are you guys gonna give us for, so you're gonna push off exam 2?
Probably like 2 or 3 weeks.
Yeah, well, through the end of
Probably the end of,
spring break.
yeah.
So when you come back, so then that week we won't have class, and then that following Thursday. So that'll give you an extra week and a half or so.
Did you get my email, Kyle?
Out
My exam. I did not take the assessment.
the first assessment.
Right.
Okay. You
Is
want to?
there any way I can make it up?
Did it lock you out?
Yes.
Oh,
It's not showing it.
okay. Let's talk to Amanda and she'll unlock it.
I'm sorry, it's 2 hours of uninterrupted time. It's just been hard to have
Yeah.
that come across.
Yeah, no, I get it.
Okay,
Yeah. And the way that I set this up is everybody's working, some are volunteers, and, you know, we have a lot of time to be able to complete this, because this is a lot of learning about the fire hose, more refreshing. So I'm very forgiving, because we're not in the same confines of a semester or GPA and student loans and all that other stuff, where I'm like, this has to be done by this date, like I can extend out for COVID. And then as spring comes around, you know, some people are gonna get deployed to fires and they may have to extend further.
Okay.
That's why I give you till the end of the year to complete everything. I don't want you, I wanna keep
Yeah.
you somewhat on
I
track,
can be
but
better on track.
I have a lot more leeway and forgiveness to extend that.
I appreciate it. Thank you.
Hey, Kyle.
Yeah.
Would you be opposed, Loetta and Walker from the station? Loetta's had a hard time making it into class on the days we're doing skills.
Yeah,
So he was wondering if there's a way he could come in when you or I are working on a Monday or
Sure.
Wednesday to
Yeah.
practice some skills.
yeah, definitely.
Okay.
I've got Lakeside. So I gotta tell you, Lakeside, the 26th, 6 to 9 roughly. I'm gonna be going down there, and you're more than welcome to come.
I just need a ride.
Yeah.
You could pick me up.
Yeah.
I'll go for sure.
And they're gonna go over some skill stuff, and so I gotta.
Oh, the 26th. Oh, that's 2 days post-op. I doubt it.
Oh, you're not going, so don't even worry about that.
I'm gonna want that here. I'm gonna try. You rest assured, I'm gonna be like, Kyle, come get me. Get me out of this house. It's been 2 days.
The 20th, we're going up to Libby. The 20th of March, so that's next Thursday. But you're gonna be,
I'm on shift.
yeah. And then the 26th, Lakeside. So that's one of the times that we're going to those places. And then we're gonna try to set up another one.
Another one.
Yeah,
Yeah, so after that, I should be good.
Yeah.
I can't drive for 6 weeks.
that's gonna be interesting.
That's a nice word for it.
But yes, if they wanna come in, Carissa, tell them, just let me know when it's good for them and we'll make it happen.
Okay.
Whatever, just have them reach out to me and let me know what it is that they want to do. And then we'll just set it up in the lab and get it done. Yeah.
He was talking to me, Loetta at least, was talking to me about drip rates. He was having kind of a hard time with.
Okay.
And then,
For like fluids.
yeah,
We have some really good fluids for those.
yeah.
And we'll probably do that closer towards the end.
Yeah, and I actually will do a med math lecture,
Yeah.
which I don't know that we built in, but
Yeah, we're gonna just add this.
yeah.
And
I can't believe I messed up the syllabus. I was so excited to teach those three. I mean, I still hop on this.
Same thing, recent.
Do you want to record them? Cause you're probably gonna be, well, I mean, it's up to you.
We'll see how the recording through it. Cause I need to record cardiology, that's more important.
Yeah.
So we'll see how far I get on that.
Okay. I'll do my best. I won't do as good a job as you do.
Okay.
But, if you are ambitious.
And I get to it,
And
I
you're in
will.
the zone, and if there's a certain one that you wanna do, and then I'll do the others.
Okay.
We'll talk about it later.
Yeah.
Maybe just one of them that you really are passionate about and wanna.
Yeah.
Record that one.
Okay, so we're gonna finish up here. I'm gonna try to make this super short with renal, the urinary stuff, and then gynecological. So we had a student at the other program that I teach in send us a scathing email one time about, so usually textbooks and especially like pre-hospital textbooks put OB and gynecological emergencies in the same lecture, right? Makes sense? And she made this huge point about saying, as women, we have things that are wrong with us not pertaining to OB. So you need to split the lectures up. So that's where this came from. So we're gonna talk just about gynecological emergencies today. and not about anything related OB. And then we're gonna do a complete separate OB lecture. Does that sound good? Anyone have a problem with that?
Isn't that the same
We-
system?
They're the same system. Yes.
Different things.
I
Like talking
understand.
about
Are we just talking like
two different abdominal emergencies.
I guess
in
one's-
different lectures because they're different emergencies.
one's prenatal and stuff? I
Well,
guess
it's not
is the
even
point, but
prenatal,
There's
just-
no
It
embryo
has nothing to do
involved.
with childbirth
Yeah.
but it's still the same organ. Yes, I understand. So here we are. So we're just gonna do quick, I mean, we've already done this when we did the renal stuff, so I'm actually just gonna, we've talked a little bit about this already, and Kyle went into a lot of this in the one that he just did, so. You're gonna get these, patients calling 911, usually for pain, right? The urinary system, so you have the kidneys, they're in the retroperitoneal area. They're treated by doctors called nephrologists, they're very, very smart people. And it is broken up into the upper urinary tract and the lower urinary tract. And, usually you can't tell what is going on with these patients. They're pretty vague, it's like the abdominal stuff, right? It's kind of a crapshoot, so just treat their pain, keep them comfortable. The kidneys are extremely interesting. You can live without one. There's an attorney in town that my dad works with who is an ultra runner and insanely fast. And she just was like, she had a friend that needed a kidney, donated the kidney, still is as fast as she was before. It was my hope that once she donated the kidney that I could keep up with her and start beating her in some races. But that was not the case. So you really only need one.
She's faster now. She's lost a pound.
Yeah, she's lost a pound, so she's faster. So yeah, they are perfused by big renal arteries, and veins that take it out. They filter blood, eliminate waste. So when, Kyle was doing his lecture on the spleen, he asked, what does the spleen do? You should go to YouTube and search, have you seen this video? Harvard Medical School did a parody on What Does the Fox Say? It's called What Does the Spleen Do? I'll pull it up at the end of class. It's hysterical. And I wanted to argue, like, so Harvard medical students, obviously you're not working hard enough if you had time. It was a production. Like, it was pretty funny. We'll pull it up at the end. It's pretty great. I almost started playing it when you said that, because I knew you were gonna say that.
Yeah, I didn't even know.
Oh, it's a thing. It's pretty funny. So there's males and females obviously have different anatomy. So the male reproductive system is all of those things. I'm not going to read them and what they do because you guys can read, right? We're going to talk about what goes wrong. Female reproductive system, same thing. It's quite a bit more complicated. There's a lot more going on, and there is a lot more pathophysiology that can occur, whether it be with childbirth or OB or without. So assessment and management of these patients. A lot of times, they're very sensitive, right? These are sensitive topics. Look for clues. Are they on dialysis? Do they have a catheter? What is their history telling you? What are their meds telling you? What is one med that is commonly prescribed at home that you might see for any of these kidney issues? To flush out the system. Well, there's two, Lasix. And then something called HCTZ, hydrochlorothiazide. If you see patients on those, they have a hard time clearing fluids from their system. Form an initial impression based on what your patient looks like. Do they have decreased urine output? Do they have blood in their urine? Are they weak? Are they shortness of breath? Do they have flank pain? We talked about that in the last section Kyle did. Any changes in urination, and then that be clued into that ultramental status for things like sepsis, right? That's a big key. So signs and symptoms of renal failure, there's a lot that can go on. Mostly the things that you're gonna see are like the hypertension, depending on what stage of renal failure they're in. They can have impaired blood clotting. They can have GI symptoms. Their skin is gonna be, if they're in like the end stage renal failures, what do these patients look like? What do they smell like? What do they?
Septic,
Yeah, I mean, they're septic. They can have a kind of an ammonia smell. You walk into these patients' houses and you can tell, right? Like you can tell this little old lady or little old man has been septic and probably uroseptic for a very long time. So assessment pearls, if they have some sort of shunt, obviously Kyle already said don't take the blood pressure on that side, or fistula of something or of some sort, don't take the blood pressure on that side. Like he said already, suspect hypotension in patients who have recently completed dialysis. They often have comorbidities. These patients are usually very sick, have not been taking care of themselves, or just have some issue with their kidneys or whatever. The thing about kidney problems is, remember, what is one of the biggest things that the kidney does? We talked about it in the acid-base balance stuff. What is one of the biggest functions, the role of the kidney? Well, it filters, but what does it help do?
Toxins.
Pressure.
It maintains homeostasis, meaning it's a buffering system. Remember, we talked about the two buffering systems when it comes to acid-base balance. What was the other one? The respiratory system, right? So the first thing when these patients start to get septic or acidotic, the respiratory system's gonna kick in as the first buffering system, and then the kidneys, the renal system is that second one. So that's a really, really important concept. And if you guys are struggling with acid base, I would go back and review that, because that is huge on the National Registry. They love acid base balance. They're going to ask you a lot of those questions. Are they acidotic? Are they alkalotic? What is, if they have this pH and this pH, are they in respiratory acidosis or metabolic acidosis? That metabolic, remember, comes from the renal system, the buffering system. And if we need to do a review on that, we will, okay? That is one of the biggest jumps between EMT and AEMT, is that acid-base buffering system, and you need to know it very, very well. Treatment for these, basically be cautious of fluids, treat for pain, and supportive care and transport. Obviously, if you're giving fluids, we're giving them in small boluses, and you're checking lung sounds before and after every time you do. So renal disorders are categorized by basically how much urine they're putting out. Are they putting out too much urine? Are they putting out not enough urine? Or are they putting out none at all? Acute renal failure is defined as loss of renal function over hours to days, usually having to end in dialysis. And then they get that accumulation of nitrogen in the blood. So do you think these patients are going to be, bless you, acidotic or alkalotic? Are they going to have too much acid or too much base?
Too much acid.
Too much acid, because what is the kidneys trying to do? They're trying to filter that acid out, and they're trying to buffer it by retaining CO2. Or retaining bicarb, sorry, flushing out the CO2, flushing out the acid. See, I even mess it up still when I'm teaching this stuff, because it's complicated. There's a lot that goes on. So here's a typical dialysis machine. It basically does the work of the kidneys for you. And then any patient that's in any type of renal failure with no functioning kidneys has to have this, or they're not going to live for very long. Chronic renal failure is irreversible. These patients are on dialysis. They're going to need transplant or dialysis for the rest of their life. There's a lot of signs and symptoms associated with these patients, especially if they haven't been to dialysis. They can get that uremia, which, has anyone smelled that when they're pretty sick? It's a very distinctive, oh, you need dialysis yesterday. And they also get a lot of skin issues too. So hemodialysis, this was kind of a cool picture. So this is what happens when they put that fistula in. Excuse me. That catheter is placed into the subclavian area. And this is that shunt. So the catheter is usually placed somewhere up here. And the shunt can either be here, or I've actually more commonly seen it, in the upper arm, like in the bicep, is usually where it's placed. This one has it down in the forearm. So lots and lots and lots of complications. Kyle kind of went over this. This is a little redundant, so I'm not gonna go over them, much, but blood clots, infections are huge. A lot of patients, these are really good candidates for pre-hospital administration of antibiotics, for those services that have them. These patients are also, irregardless of whether they have been hemodialyzed or not, hyperkalemic. So there are some protocols, I'll be honest, I don't remember, I think we can give calcium for that, if you see it on the EKG, to help pull that, pull the, oh my gosh, the potassium brain work, out of the cells, right, that's what calcium does. Kidney stones, we already talked about these, right? UTIs, we already talked about these. Foley's, huge incidences of infection. When I was in my clinical rotation, it's so cool, I'll show you pictures, I was gonna put them on here. Have you heard of purple bag syndrome?
No.
So it's a type of bacteria that's very rare. And this guy walks into he walks with this catheter bag and he's like, so I have an issue. And I'm like, okay, what's going on? He's like, my bag's purple? My urine is purple? And I was like, yeah, it's really purple. I'll have to pull it up. And it is, it's a bacteria that actually gets just into the bag itself. But it can get into the system, right? It was very interesting. I have a whole PowerPoint thing on it. And it's like one in, there's 3,000 or 4,000 documented cases ever. And I got to document one of them. It was pretty sweet. We were in Boston and I was like, look at this. So.
Oh, do you want to just touch on catheters? Like, don't just yank them out.
Oh, yeah. Oh, yeah. So obviously there's a balloon in there, as you can see, same in males and females. And that balloon needs to be deflated. So don't ever yank them out. One common thing that you can and probably will see if you have nursing homes in your area is patients who are altered will be pulling on these things. And a lot of times you'll get called for transport of a patient who has pulled their own catheter and is usually bleeding and in a lot of pain.
Is it always through the urethra?
It's not.
Okay.
Okay, so there's a couple different kinds. There's the normal one, and then that is normally through the urethra, and then there's something called a suprapubic catheter. That is surgically implanted. They're usually permanent, usually don't get off of them. And we had a frequent flyer, I bet she's dead now, in South Kalispell, that we went on all the time because she would pull that thing out or it would get infected.
Kind of looks like a colostomy bag, but smaller.
Yeah, yeah.
And you gotta drain it.
And you gotta drain it, yeah.
Or some people also have leg bags, especially men, if they're having prostate issues, they'll have, instead of carrying around that big bag and they still want to be mobile and go to the grocery store, they may have that catheter taped along their leg and then they have looks like a little bag on the leg itself. I see that.
That one's pretty common,
Or
yeah.
they might even do a straight cath, so they can't urinate or very little urine. So they'll straight cath themselves when they urine, and then they don't have to have a bag or that leg bag.
They actually.
They do it
service
themselves,
this
yeah.
Just for the.
Just to.
Multiple times a day.
Yeah, like when they feel like they have to go. Yeah.
That's what they
Wow.
can feel the urge to pee, but
But
they
they
can't.
can't for whatever reason.
Because usually it has to do with the prostate. It's
Oh.
enlarged. They get that trigger. Remember there was a movie, what was it? The Godfather was like, I'd give $1 million to piss if I could get a good, and that's because his prostate was
Yeah.
just not allowing him to get
Yep,
full
it is the Godfather, yeah.
relieving of the prostate.
So lots of problems. Like I've already said, patients who are confused tend to pull these things out. Critically ill patients get these, you get infection. And then if you have a patient with any sort of like paralysis, they're gonna have to have a catheter. Be aware when you have a patient with a catheter of those sepsis protocols, right? Just go down that list. Are they altered? Do they have a fever? Can you have sepsis without a fever?
Yes.
Yes. So it's called cold sepsis. For a long time, people didn't believe that it was sepsis because there's an infection, there has to be a fever, right? And the research is very much saying now that is not a thing. So cold sepsis is very much prevalent. So that's why, like in our sepsis protocols, there's criteria, and that's that's not an absolute criteria. You just have to meet a certain number of check marks to call sepsis protocol. Not all of them, so. Okay, so emergencies with men. So this is a really big one. When do we see priapisms? Mostly for us in the field. Trauma to that lower spinal cord. If you have a priapism in a man that is an erection lasting longer than 4 hours, it's a medical emergency. They have to go in with this barb, which looks extremely painful. It's literally like a fishing barb, and they go in and drain the blood. I've seen it happen a couple times, and as painful as it is for that patient, the relief that they get from draining the blood is pretty like noticeably different on their face.
We had one where he was using a herbal supplement
Oh,
for
interesting.
erectile dysfunction, and it ended up causing a erection that lasted for several days. They kept having to go in and drain and no change. And so then finally they had to go in and then surgically prevent him from ever being able to have an erection again.
Yeah.
So he sued the herbal company because there's no warning, but it's because they didn't really know, because remember, it's a herb. it's not-
Yeah, they're not FDA, they're not
And
regulated.
he got $200,000 settlement. Is that worth it?
Doesn't seem like a big settlement, yeah.
No.
Yeah, no, that doesn't seem like a lot of money.
So if somebody does, if a male has a priapism, another one is those that have sickle cell. males.
Yep, sickle cell disease.
Oh,
It
I'm
is up
reading
there,
this one.
yeah.
Sorry.
No, go ahead. Yeah.
Sickle cell. So you may see that with sickle cell emergency is that for priapism. So just be mindful. Don't have the sheet and a teepee when you're walking out to the outside world and down the hallway. Try to use something that.
Do you actually know the pathology behind the sickle cell? Cause I don't, I
I
just
don't
know that
know
we've
that
always
it's-
been taught like that's,
It binds and it gets trapped, and that's what's keeping it
Okay.
from draining. But I'm not a
Yeah, I
sickle
don't-
cell expert, but I
no.
just have seen it enough times. That sounds creepy, but
The trauma's a
I have
primary
had-
cause.
primary one that we're
primary one, but then I've had sickle cell males that have come in. They're usually African American, what I've run into.
Yeah, so sickle cell is much more prevalent in the African American population. They don't exactly know why. The data's not there. Have you guys been on sickle cell patients before? Have you seen the one, they're not very common, the chest thumper thing that they have to have on like several times a day? It's like it's a pneumatic vest that basically just breaks up all the secretions. And they're extremely expensive. But they work really well. So a lot of times you will see those vests with the sickle cell patients. Sickle cell is much more common in African Americans and females. You don't see it a lot in males, and it's because it is it's a sex-linked disorder. So that's why. Now the African Americans, I don't think they know. So testicular torsion is a medical emergency, right? It is extremely painful. A lot of men get very embarrassed about this. It's just something that happens. It can happen, it can occur spontaneously, it can occur from working out too much. And usually if this is not reversed within, 6, 8, 10 hours, that's pushing it, but like very quickly, they will lose their testicles. Patients are they're gonna be in a lot of pain. They're not gonna be able to walk, they're doubled over. I've had several friends who have had this, who have called me and been like, I need to go to the ER now. I don't know what's going on. And a lot of times, it's very interesting. Where are they gonna get pain? Where are they gonna describe their pain as? It's not gonna be in their testicles. It's gonna be like lower abdominal. It's gonna radiate. It's very, very interesting. The two friends that I have were just like, actually, they thought I am having appendicitis, like, because I have lower abdominal pain. It's not all the time like where the problem is occurring. So think about that radiating pain. It's also really common in little boys too, like little kiddos and toddlers get this fairly frequently.
My brother had it when he was like 6.
Yep, yeah. For whatever reason, I think probably part of it is because they're super active.
Your friends didn't have any other symptoms or anything like
No, just abdominal pain.
And we
No.
definitely made fun of my brother for way too long.
Right.
Yeah, because he was
So-
6, like,
Yeah. Yep. Like it's and kids are hard because they don't know how to describe pain,
Mm.
right? Like I have a 2.5-year-old who's always like, my back hurts, and I'm like, oh God, do I take you to the doctor? Is it just because mommy complains of back pain all the time? You know, you're just mimicking your mother. Okay, so female emergencies. This has nothing to do with OB. This is not with the baby stuff. This is just female gynecology. That was my disclaimer. Okay. So there's a lot of different things that can go on in females. We are very complicated when it comes to reproductive organs. You can have pain with ovulation. Ovarian cysts are very painful, especially when they rupture. Endometriosis is extremely common in our population today. It has a lot to do with, in my opinion, hormones that are put in food, the things that we've been exposed to, pesticides, all that kind of stuff. Ectopic pregnancy, so I did mention that one as something that you need to rule out. When you're asking these patients questions, it's very important to ask last menstrual period. Is there a possibility that you're pregnant? Are you on birth control? Are you taking your birth control regularly? And where this becomes really an issue is in teenagers, right? Teenage girls, teenage women, because there's the issue of consent to treat, and then, you know, they don't want to say things in front of their parents. And we'll talk a little bit more about that when we get into, I think we already did development, didn't we? Yeah, we did. So yeah, so we've already talked about that, right? And then PID is a secondary infection that usually happens after some sort of STD, especially untreated STDs. Abnormal vaginal bleeding that's not associated with pregnancy can very much be life-threatening. This is a great one to use TXA on. It's very much indicated. Women can have heavy periods, usually not calling 911 for that, but if they are, take them seriously because there's like something's going on, right? If a woman is calling you because of pain during whatever, and they're bleeding, there's something going on. Really watch these patients for signs of hypovolemic shock. It's really important to ask them how many sanitary pads they have soaked, because
what thickness?
And what thickness, yeah. That gives you a really good indication on how much blood these patients have actually lost. Yeah, you never pack anything into the vagina. Just make sure if you have to, you can pack the outside, right? Just like you would any other bleeding. So I'm gonna make a note about transgender patients. We have all treated them in the field. The thing to remember is that you have to treat them when it comes to these kind of emergencies as the sex they were assigned at birth. It has nothing to do with politics or what you believe or what you feel. It has everything to do with physiology, right, and anatomy. Just be sensitive to these patients. Ask about the big things for these patients is ask what hormones they're taking, if they're taking them regularly, how long they've been on them, and just respect these patients.
And surgeries.
And surgeries, have they had the surgeries yet? Because if they haven't, if they haven't, that's, you know, those are big clues, right?
If it's the male and they have created a surgical created vagina, then one of the things is they have to put something in there to keep the cavity there. And so sometimes they're also very susceptible to infections and also that opening that was created wanting to close.
Yeah.
And that creates a lot of complications. So these transgender patients can be very complex in trying to treat and take care of, depending on which sex they chose to surgically change to the other one. It can get very complex very quickly. And you also got to address sometimes the psychological effect that it's having on them. So you can have two things going, a medical emergency and the psychological trauma that causes to those patients.
And I admittedly don't know a lot about the surgeries. So if I had these patients, which I have not for a while, I would just ask, right? If you don't know, just ask them, right? They're usually very open about talking about it. Yeah. So STIs, obviously, we're gonna have patients that have these. Not a lot of times are they calling 911 for these, but remember, always use your precautions. The big ones that we need to worry about are the hepatitis and HIV. And most agencies strongly recommend, they don't require, but strongly recommend those vaccines for healthcare workers for hepatitis. And then be wary of like things like HIV. So just always wear your gloves, kind of things. Don't be licking the blood. you know, common normal sense things. I'm sure someone has somewhere. So, and then just a summary of all of the things. This was pretty repetitive as to what Kyle talked about. The book goes into a lot more detail on like the gynecological stuff, and you can read about it, but it's just not patients that we're gonna see all that much. We're not gonna spend a ton of time on it.
And most of the time, what are we gonna do?
Supportive care and
Support
transport.
and transport for these types of patients, because they're more complex.
And as you're walking out, I will play this YouTube
We
video.
need doctor help, not
Not us.
necessary.
So for vaginal bleeding, you guys said TXA, what about external clotting? Like quick clot or anything?
You could. I mean, I don't.
I would get a doctor's order for that.
Yeah, for
Okay.
that would be
That's
one
gonna
that I would.
You're using, I would not be putting that into vagina
We're not putting anything in, but yeah, so externally, yeah.
or externally. I probably would not.
Okay.
If for some reason you have some rare circumstance, because that's not what it's intended for, then I would get on the phone and ask the doctor, this is what I got. I can't get this bleeding to stop. Do we use this? This is an idea I have.
Okay.
And that way you're getting an order, because if it goes wrong,
Yeah, yeah,
they're gonna
fair.
go, where does it show in your protocol to use that type of,
Okay.
to do that type of treatment? And they get paid a lot of money to answer your calls.
Yeah,
So
yeah, yeah.
when in doubt, I always
Yeah,
remember their knowledge and experience, and they're gonna be treating that patient when you drop them off.
Mhm.
You wanna make sure you're on the right page of, this is how they're gonna go treat it, and this is helping that treatment. not
I'm always
making them-
pretty hesitant to use hemostatic gauze in any situation.
Yeah, it's kind of controversial
It is,
already.
it's controversial, so, I mean, I carry it with me everywhere I go, right, in the backcountry. I always have, the only things I carry medically are quick clot certificates. But for routine patients, we have other ways of back the ambulance. It's controversial. The long-term effects of it are very unknown. Surgeons do that stuff. Having wounds after that, I've heard is just a nightmare. So obviously, it's gonna save your patient's life. We'll deal with the long-term consequences, but yeah. But good question. You two were all over the questions today. You stumped me a couple times. Yeah, man. So this is Harvard Medical School.
You guys have favorites for YouTube people for videos and stuff? or
Osmosis, really like them.
Osmosis? That's the name of the YouTube.
Yeah.
Khan Academy is great.
Yeah. Osmosis will take some of those complex topics. They visualize it, break it down, and then summarize at the end. They also merged with Kaplan, one of the publishers,